control. So it's something that we need to continue to work on, because clearly we need physicians in the hospitals and we need physicians in the community to deliver on our goals.
Hey, Katie, thanks for meeting with us today. One of the slides that you had talked about the remedies that the HSCRC was implementing to respond to the total cost of care crisis. And one of them was the increase in the public payer differential by 1%. And you indicated that it's revenue neutral to the hospital because typically that goes through our markup calculation. So it really pushes to other payers. So my question is this: if that actually happens around March or April, and I think that's what the slide indicated, because it would take a while to get that approval, can hospitals expect to receive another rate order so that we could, because what I'm thinking is if it has to go through the markup, then we need another rate order in March or April, and that could actually impact compliance as well. So I'm just trying to understand the mechanics of a mid-rate order change in that differential.
Yeah, and that's a great question, and good to look forward in terms of making sure we are on compliance. I anticipate that we will have a heads up from the federal government as to whether they approve or not approve, even well before it's able to be implemented. So I think to the extent that we are able to get it approved, we'll have some time before it goes into effect. And so we'll be able to work with the hospitals if new rate orders are required. I'm looking to Jerry to see whether he thinks they'll be required. But in any ways, for compliance purposes, we definitely will make sure we take that into account. Good question.
Any other questions? Well, thank you, Katie, for your time. All right, so a couple of things. One, I didn't introduce myself. My name is James Case. So it's great. It's great to have you guys again. So James Case. So I'm the one that's getting all the questions that you're getting questions from about the streaming. So let me put your minds at ease. We are aware that the streaming is not working correctly at this moment in time. So as your colleagues back in the office are texting you, and then you all feel obligated to tell me, I am aware. So we are working on it. We're having some internet issues here at Martin, so we'll get on it, we'll get it fixed, we'll carry forward. But I am James Case. I'm a partner at KPMG's healthcare advisory practice, and I'm your host for today. I'm a former past president. So if you do have things that we can do to make your experience better, by all means, all kidding aside, please let me know, and I'll let the Martin staff know. We want you guys to have a good experience today, both virtually and in person. So our next speaker, we'll get right into it. We'll have Mr. Brett McCune come up to the stage. Brett's the Senior Vice President of Healthcare Payment at the Maryland Hospital Association, where he works closely with Katie and the HSCRC staff and the commissioners to develop fair and effective hospital rate setting policies, and is an advocate for MHA's member hospitals. He serves as a field expert in reimbursement, financial policy, legislative, regulatory matters, and also advocates on behalf of the hospitals for important issues in front of the MHCC, MDH, and the Maryland General Assembly. Before joining MHA, Brett was a managing director at KPMG in our healthcare advisory practice, where he led many major consulting engagements with a lot of you all sitting around this room in the Mid-Atlantic. He's a longtime member of the chapter, a former past president, a region exec-elect, and has done a lot for HFMA in addition to speaking here every year. So thank you, Brett, and let's get going.
All right, thanks, James. You got to turn this down like five notches, right? All right, good morning, everyone, and thanks again for joining us this morning. I really appreciate this. This is great to be back and see all the people in this room. I really enjoy this event every year because it just brings out such a wonderful crowd, I think, from senior executives, all the way down to brand new folks, starting their careers. And I think this is a fantastic event to bring everyone together. I would also echo what Katie said earlier. I think, I always start this, we are very, very, very blessed to have the HSCRC and the quality of the HSCRC staff here in the state. Katie was not kidding when she talked about, the staff being the best in state government to deal with, and they are absolutely wonderful. That doesn't take away, there's times my dog thinks its name is what the heck is Jerry doing now? But I would recognize the staff because it's, as I say this every year, it's not like if you're doing CMS policy, you can pick up the phone, get somebody on Security Boulevard, and get them to listen to you and actually, think about it a few times before they might change their mind and have a hospital-specific consideration. So we do have to recognize that, with all of the frustration sometimes, that we are very, very blessed to have this system in Maryland. So let's go on to the next slide, please. So that's me. At the end of the session, you'll see this. I'm going to talk about, the hospital field's perspective. This will be a bit generalized, but our perspective on these big topics. First, about our model performance, future extension. Katie talked about that, a little bit. That really is the linchpin about how we drive this system forward. We'll talk about the upcoming annual payment update. I certainly know that's a challenge. We'll get a little bit of flavor of what's going on. I know that some of my colleagues are going to talk more about that this afternoon, about the financial situation we face here in Maryland. But we'll talk about the annual payment update. What are the important considerations? And then overall policy alignment. I think that is clearly a challenge right now about how we align ourselves under this system. And I am going to ask some interesting questions to folks that may be a little bit provocative when we talk about that and what our system looks like. It wouldn't be an MHA session if I didn't hit our legislative priorities. I'll go over those quickly. I know Megan Renfrew from the HSCRC is going to talk more about at least the debt collection financial assistance and what's going on around that. Lots of legislation and changes about those things. So I think, we have to, when I talk to the regulators, and when we look around the country, I think we have to recognize, right, this is a very, very different landscape over the last, and it really has been probably the last 15 months that we've seen this, that we've seen volume, we've seen financial devastation. Why is everything so strained? There's no turnaround in sight. What is all this? What does all this mean? We see these headlines every day. I mean, everybody who gets the HFMA Daily News Scan or Healthcare Innovation or, Becker's, which is like the TMZ of like healthcare finance, news that comes out every morning about, okay, here's a teaser and, go find celebrity on page 2. But this really is a challenge. And I think one of the, and Katie and the staff acknowledge this, right? The difference for those of us, and God, I can't believe I've been this old, to remember the system correction factor when the feds introduced the Balanced Budget Act there was a 19 in front of those numbers, right? And so we remember that when the commission reduced rates 4%, in 1 year, like actual reduction 4%, okay? That was a very different time when volumes were variable and there were a number of different things when you measured it that way. But at the time, margins and the financial health of hospitals were very strong, right? Our challenge right now as we think about maintaining our agreement with CMS is that, we haven't seen, I don't think anybody in their careers have seen this type of, financial struggles that we've seen now from a hospital and health system perspective. So as I talk today, it's against this, backdrop as we think about the system and what that system looks like. And by the way, if you have questions, just raise your hand and we can answer questions as we go. So real quick, when we look at this, this is the hospital capacity as of last week. So the green on the bottom, those are the COVID cases that are occupied beds in hospitals. So if you think about it, look at the big spike last year, right, in January and where we were. The blue are the non-COVID patients. And this, again, the 7-day rolling average. And then you see, okay, so what do we have? The gray is the number of staff beds that we have. And the white above that would be the number of physically available beds that we could staff. So, as of recently, we were at 92% occupancy. This was, that last week. And we know it's not COVID, right? The COVID, it is running a bit higher right now, but it's not COVID. So everybody is at this challenge right now about the beds you're trying to staff. What does that look like? How full are the hospitals? We know that at 92% occupancy, we know that the operators and those managing the floors and truly managing the operations, it's really a challenge to operate that full. Let's throw into the mix the contract labor issues and what we're spending on nursing and what we've seen. I may have some of that in here, but if not, I just like to present this statistic. If you're at the Annual Institute, you heard this. Prior to the pandemic, Maryland collectively your hospitals spent about $100 to $150 million a year collectively on contract labor. Okay. In 2022, we spent $1.2 billion on contract labor. Okay, let that sink in for just a second, right? And you can talk about all the number of reasons for that. We have seen that come down. But what is interesting, right? We have seen that those contract labor numbers come down. But as a percentage of salaries, right? We've seen the permanent salaries go up. So this is not. There's the hydraulics and mechanics here. And I do, want to point out that as we'll get to this, that some of the reason that we overran the 2022 performance is the fact that the HSCRC was a great stabilizing factor for us here during the early part of the pandemic when nobody knew what was going to happen and we had guaranteed, global budgets. And that, of course, is just rippling through the system now, and we have to recognize that. So, again, this is, the current state of the world around the occupancy. I think everybody recognizes this, right? So we are trying to have a delicate balance here between what we need to do to meet our model goals and targets and what those true cost pressures are. We know that we overran the 2022 measure. I'll talk more about that in a little bit. We have to negotiate a new savings target with CMMI. And we have to negotiate new terms, of the model. And there's different paths forward for that, right? I would say one of the key messages from the hospital field is we're looking for long-term stability. We've seen, with this model, the year-over-year guardrail and that, interim guardrail has been a challenge because we had to manage that. And certainly the 2022 performance has been a challenge because we have to manage that, right? We do not have the statutory protection that we enjoyed for a long period of time under the old pre-2014, IPPS and OPPS waiver. And that really provided, long-term stability, but we have to come to a new contract. And of course, as Katie mentioned, the biggest thing in this is uncertain national growth because this is a per capita measure, which includes both volume and price. So if you look at the feds, right, they can regulate the snot out of prices, that's a technical term, all they want, right, down to, 10, 20, 15% below cost because they're expecting volumes to grow, right? And all of a sudden, well, what happened nationally is that probably because of the contract labor and the labor crisis and everything else, when it costs $1.20 for every dollar of revenue you add, right, it doesn't make a whole lot of sense to grow volumes in that market. And so, what we see then is, we saw a slowdown nationally, at the same time, we were seeing the last of our stability kind of come through the system. So there's a bit of uncertainty up there as well. So, I'll go just a little bit longer on that timeline. Where did we come from? Where did we go? So right now, when we talk about the new model, right, this is a true function of just not only the HSCRC's regulation, but there are very much, the politics in terms of how we get this new model negotiated and what does this mean. We're in that 23-24 period. We have to come up with a proposal under our contract to extend the model. So right now, right, CMS is under the Biden administration. So if we believe, in 2023, and that'll be decided by the end of 2024, right now is the time when we're going to have to go through that process. So last time I checked, this was a Democratic administration, and Maryland leans our delegation is, largely Democratic as well. So we have that, connection right now with the Biden administration, and how do we, talk about that and use that going forward. We also know that we just finished the Hogan administration and we've transitioned to the Moore administration. So we have a brand new, last week was the inauguration, we have a brand new health secretary, and how we, work through this whole process with the staff, with the hospital field, to take the model forward. But we have this year to decide what we want, and how they'll decide the extension by the end of 2024. And then of course the next presidential term, would go after that. Now, one thought, we've heard this from folks, is, this is the old, we're still trying to figure out what just happened with COVID, right? What caused our 2022 performance, and do we expect to see a big turnaround where it would be a very different performance in the future? I mean, prior to 2022, we did great. We were doing fantastic under the model and meeting all of the terms of that. So I think as we think about this all plays into, what does that next model look like? What are the important considerations from the feds, from the state, and how we, address those? So this was the CMS Evaluator Mathematica. Katie may have touched on this for a hot second. CMS has to have an independent contractor review every demonstration model's performance. Our model is a demonstration model. And under the federal statute, it says you either have to lower costs without reducing quality, or you have to raise quality without raising costs. So that is if you just look up 1115, whatever the section is in there, that's exactly what you see. So the feds look at that and say, how do we independently do that? And so Mathematica, their contractor, and they see this was through 2021. So important, this was pre 2022 experience. But it was about the most favorable report we could possibly imagine, right? That came out. I mean, it was, compared to a matched peer group of hospitals across the state. This is different than what our contractual provisions are. They're doing an independent evaluation, say, if we didn't have the waiver, this is what a conglomerated state of Maryland would look like. Not surprisingly, our admissions, our ED, our volume down much faster than the peer group. Our Medicare overall spending per capita, hospital spending, all of these different things. Our post-discharge visits were up 2.5%. Makes perfect sense because under global budget incentives, right, you want to keep people out of the hospital. So our performance was really, really good, and we outperformed the U.S. on 11 of 14 measures with the mathematical report. So this is a good tailwind, going into this discussion. Let's go to the next slide. So, Katie talked a little bit about the savings, and this is sort of a graphical representation of the savings and where are we. If you look at the left-hand side, the green bars are what actually occurred, through 2019. We were doing great, right? We were beating the financial targets, largely because we implemented a system to put bigger incentives in to constrain volume growth, right? Medicare does the opposite. They ratchet prices down below costs, so hospitals outside of Maryland shift it to somebody else, or they grow a boatload of volume to make it up, despite the other incentives that maybe there with ACOs. It's not like the real Maryland incentive, which is here's your GBR, have a nice day. We see the gray part being the pandemic in the middle, where we actually did okay even during the first 2 years of the pandemic. You see my number for 2022 at 160 million versus Katie's at 80. We're likely going to end the year with $80 million of real savings. What will happen though, January 1st of this year, we did reverse out the very last of the one-time adjustments. And we would expect coming out of the gate, the tailwinds to be, up to add another 80 million of that. And so we think we'll be out of the gate at $160 million just to start with before we start measuring what the savings will be next year. So really, looking at, well, we have targets set through 2026. How do we get back up to those targets? We have to save $408 million by 2026. So very conservative, and we just reverse the amounts. We're going to start at 160 million. So the question is, the red line there sort of parallels what we saw before the pandemic. Does that put us back on course? And that's what CMS and CMMI want to see, right? They want to see us get back on course as we move up to this. That's why we did have, the corrective action improvements likely to boost that curve a bit versus if we just followed our historic trajectory, right? Again, we have argued and we have talked about this with the HSCRC staff, and our members have said, look, we don't know what the end result of COVID is. And I think CMMI, to some frustration, and others, we just had a once in a 5-generation pandemic, right? I don't care what brilliant model design you have there was never going to plan for something like this, right? So, our point is, this is let's take the opposite. Don't just do something, stand there, right? Let us think of what this model looks like. Actively working on this. This is sort of the equation that we have to think about and about how we, garner savings in the system. We would also talk about, for years, we just regulated prices in Maryland, right? And interestingly enough, and I bring this back up, if you think about the mathematical report, we regulated prices for 40 years. I'm looking at Jerry, 45 years. So pre-pandemic, hospital expenses per capita on an all-payer basis grew 6.8% per year for 10 years, okay? We put the GBR incentives in place. First, we set the target at 3.58%, which is the 10-year average of the gross state product. So last time I checked, 3.58% was well below 6.8%, right? And then we've come in at about 2%, little more than 2% per capita growth. So we think about that. I mean, you talk about powerful incentives that have changed the marketplace. That's been some of our messaging to say, look, this is really, and CMS, they see it. It really works because this is the only state where we have significant control over volumes, right? And this is a key. Now, here's my question to everybody. So how many executives in your hospital or health system, I'm talking to hospital people, I see my payer friends over there too, but I'm going to talk to the hospitals and health systems for just a second. How many of your executives like the fact that there are constraints on, that there is a revenue limit for volume and program growth? How many of your executives really dislike that there are constraints? It's okay, don't be shy, we're all friends here. Okay, I see the hands, they're just kind of generally because they don't want to actually put their hands up. How many of the hospitals and executives appreciate the much higher level of Medicare and Medicaid payments and shared uncompensated care here in the state? Right? Those two things balance each other out. CMS wants transformation in exchange for our higher Medicare and Medicaid payment rates. And absent that, right? Absent that, we would be in the same boat as everybody else. And you can't pick up Becker's or HFMA without seeing X hospital close. Because they either don't have the volume, they can't cost shift it enough to the private payers, right? Or they can't go beg the state and local government for money, right? And you get two-tiered healthcare anyway, right? I forget, I looked at this up. I mean, like the DC government, it was like an obnoxious number that they were subsidizing hospitals that we don't have, here in Maryland because it's built into the rate structure, right? So CMS is looking, as they're thinking about the model going forward. Go to the next one. Go back one more time. So I think probably many of you heard me say this. CMMI, right? It's a bacon and egg breakfast, right? So they want Maryland to be a pig and not a chicken, right? The chicken plays a role, but the pig's committed in a bacon and egg breakfast. So they want, Maryland, to be all in, with my apologies to my vegetarian and vegan friends for that. They want to make sure Maryland is going to be a pig in this conversation, right? They want all in buy-in to, care transformation and other things. Let's go to the update factor. So, all right, here's the considerations, right? Right now, the market basket inflation factor that we use as sort of a baseline is 3%. So we know that our challenge is, meeting the Medicare contractual target versus funding inflation, all right? That was laid bare, and you can go back and watch the video in the conversation at the December public meeting when, we MHA made it a clear point to say this system has got to fund cost inflation. And I think the response was this system has to meet our contractual obligations. So I think there's a balance for both here, right? Our point has been, yes, there is a Medicare target in the contract. There is also an all-payer target in the contract, and it's an all-payer hospital system. So we do look at Medicare total spending, and that's important. But we also, we firmly believe that we cannot financially strangle hospitals here with respect to, funding cost inflation. And that has been a long standing position of the commission. The commission has historically, always funded cost inflation, except in, real situations where we were immediately going to, to fail the model. You could argue where we are now, but again, we are also much financially, we're stronger, right? This is a super challenge. And I can kind of play a tape recorder of a loop of some of the discussions that we have about this, around, what is inflation, what are hospital reserves, et cetera. Now, MedPAC did recommend that Medicare add 2.8% to cost inflation to make up for the last 2 years. That sounds awful familiar because I think we testified to the same thing last year, that we've been underfunded on cost inflation. We're going to expect 2023 Medicare performance to improve next year. We've done these temporary things, but even beyond those temporary things, we put $200 million in the rates in 2022 because of the guarantees from the COVID period. The commission said, we will guarantee your global budget. That finally washed through the system all in 2022. In addition to the $100 million advance that was in the first 6 months, not in the second 6 months. So that first 6 months looks so much higher. Hospital revenue grew 6% in the first 6 months of 2022 compared to 2021. So not surprisingly, when Katie showed the graph earlier, that overall total spending grew 4%. Okay, let's normalize for that, right? It's always easy math here to remember the hospital spending is about half of total spending in Maryland. So if it grew 6%, let's say the hospital spending really grew 4%, which was closer to inflation and other things. So there's a 2% difference, you multiply that by 50%, there's 1% off the total cost of care growth rate right there. When we talk about the change in the actual delta of what the growth rate may be, it may even be, be bigger than that. So we know that's going to come off, we'll have to see that. I think we are going to have to carefully understand what CMMI's responses are, both to just our performance in general in 2022, and we are also waiting to see what their response is to raising the differential. I think and I was around for this and involved in this, when we talked back to the first all-payer contract and the total cost of care contract, there is language in there that says, that we specifically said, if you meet the all-payer growth test and you're having trouble with the Medicare growth test, then you can adjust the differential, right? We don't take that lightly. It's an all-payer system. We don't really take that lightly. But at the same time, if Medicare is limited to X, or the fact that volumes and everything else are limiting revenue, and we have to fund cost inflation in the system, right? I think that's something we honestly have to look at, and we are well below what the all-payer hospital growth rate limit has been. right? We set it at 6 point, or excuse me, it was historically 6.8. We set it at 3.58. We've grown it 2, right? Like this is like, okay, we recognize the ceiling's growing, but do we really need to start digging holes in the floor here? Like we got to figure out like how we fund the system. And we certainly know margins remain depressed. We've seen this. We get this, monthly, every month. I know Neil Patel and Laura Russell from NHA are going to talk more about the financial position later. Go to the next slide. This is the when we talk about the inflation underfunding. If we look at the cost shock period, right, the last 2 years, and again, this is just compared to what IHS's market basket is. This is not compared to what CPI or anything else is, which would be, a huge delta there. And that's about a 3% difference when we look at just 2022 and 2023. And of course, to be fair, right, the commission says, well, we actually did give you more than inflation over a period of time, as Mr. Smith, and Mr. Henderson and others remind me during the first part of the model. And we didn't take that back. Very true, right? So go back to the left-hand side. But even when you account for that, we account for the ups and downs. The fact is that the inflation underfunding difference was so big in the 2022 and 2023 period, right? Now back to the beginning of the model, there's still a 1% gap here. So that's between 250 and some $600 million, right? What would be really interesting, and this is something that we are trying to search high and low for. Medicare, we have the data, we can look at Maryland, we can say, here's the hospital spending growth and here's the total spending growth per capita. On the all-payer side of things, right, we can look at our hospital all-payer spending growth and we can measure that. There aren't good comparisons with that nationally, right? The holy grail, in our opinion, would be if we could find a comparative growth rate for both hospital spending per capita on an all-payer basis and total spending per capita on an all-payer basis. Because one of our points is, the Medicare piece, the price differential for Medicare, that is just simply because we don't have public hospitals here in Maryland. But again, this is, a point of contention as we think about that. That would be, if we could look at that and say, okay, really, when we look at the all-payer revenue growth, has that been higher or lower than the rest of the country? And if you could allocate that across Medicare, Medicaid, the commercial payers, et cetera, then you would get a clear picture of, okay, what is our revenue growth compared to Maryland? Are we lagging? Are we the same? Is it higher or is it lower? And that would inform, that would really inform that picture. Here again, the margins, the red margin is Maryland, the dotted line margin is the nation. From Kaufman Hall's flash report. We can see, during periods of time, we did get the provider relief funds. We recorded those back in 2021. And then really, September, October last year was when we saw the spike in contract labor and we, really saw the change. And we've been, under the national margins, ever since then. Go to the next slide. How are we doing on time, James? Wrap it up? All right. So he told me I could go over. He told me I could go over since we started. This is the difference in I just mentioned in that all-payer growth, right? So compounded our 6.8%. This is what's built into the contract. I do know I should put a disclaimer on this. We are working with HSCRC staff to reconcile the last 2 years of this. I think we have some different numbers, and this may be a little more narrow. But still, we are still well under the all-payer hospital target, hospital growth target. And this is where, if we truly have a hospital system, an all-payer system, how do we reconcile the all-payer hospital growth with our Medicare performance, right? This is the conundrum, that we face without, truly looking at the distortions that we have in the rest of the country. And again, we don't take this lightly, but at the same time, our hospitals are saying, this is, a really calamitous time, and just having to understand, this. Go to the next one. Okay, so the policy landscape. This is another, sort of key perspective from the hospital field and the commission's, point of view. At the January meeting, the commission staff and commissioners talked about, what are the system's aims driving towards meeting the targets in the contract, right? And then under that, what policies does the commission need to meet those aims? And that really leads to a very tactical conversation about what policies the commission should revise, remove, add, etc. This is a real tricky world right now, right? Because to be fair, the commission, we're trying to balance the per capita system incentives with appropriate hospital funding, right? Go back to the fundamental question I asked you just a minute ago, right? We live under the constraint, under the very severe incentives under the global budgeted revenue system, which is a very different set of incentives in the system. And at the same time, commissioners, other hospitals, and others are saying, well, how long do we get to keep the retained savings in the system? And there are two schools of thought on this, right? One school of thought is, if the minute you start messing with the retained savings in that system, you will undermine it and reverse it back towards a fee-for-service system. And the cynical view of that is, in a fee-for-service system, volumes will always grow, or at least volumes will always try to grow under a fee-for-service system. And that's what we historically saw, right? At the same time, to be fair, others have said, well, how long did you think you were going to get to keep that, right, in the system? And if we don't do something about, this revenue in the system, or, the dreaded C word, capacity in the system that brings fixed costs and other things with it, how do we address that? Because, will we continue to be in trouble? And there's different schools of thought on that. One school is, as long as you're under the targeted growth rates, then, the incentives work. The other school is, we're not going to remain under the targeted growth rates unless we deal with this. And I think, underneath of that, there's the question of market shift, efficiency policy, all of those tactical things. And all are a challenge because, as all of you know, revenues are not variable with volumes in the system, which means all of those policies are indirect adjustments on revenue that are based on some indirect methodology calculation to redistribute revenue or to remove revenue in the system, right? It would be really simple. I mean, and I grew up in the simplicity. It would be really simple, price times volume equals revenue. And you change that and you figure that out. But that's, that's not the incentive in the system. So we are working with the hospitals to say, where can the hospital field find common ground on these positions, and what does that look like? And are there things that we need to take into account that are the unique, we've heard time and time again about the unique circumstances of hospitals, and we understand that, and that'll be part and part to our, to our discussion. Again, we've taken this through our councils, through our executive committee, but overview of our financial, of our modelings, and you can read these. I think some of this is motherhood and apple pie. Some of it's challenging though, right? So the top one, ensuring financial sustainability for the model and health systems collectively, right? We recognize if we said we want to ensure financial stability for every single hospital, well, that may not be viable in certain markets. And what is the glide path for that, right? We have seen, I'm looking at the university folks, we have seen conversions to freestanding EDs, from some of the inpatient hospitals. We've seen some of that. But key, all payer, provide fair and appropriate all payer inflation / input cost funding. So that's inflation and capital. And what do you do about that? And what does that look like going forward? I think, trying to appropriately align revenue to meet resource needs. I know appropriate and align are two, big words there, but trying to, to meet those things the best we can. And again, same thing with service capacity. And then the other two, of course, we need to produce per capita savings because that's our incentive, right? That's the model we signed up for. And we have to continue to deliver that. Maybe there's an opportunity to talk about, different ways, different measures and other things to change that. And we are working at, our executive committee level with hospital executives and engaging with what will be, HSCRC leadership and the new health secretary at the highest levels about what does this new model look like and, what's the best path forward not only to give stability for, our model in Maryland, but also to bring financial stability for hospitals as well, and for the healthcare market. And then, of course, we will continue to strive. I think North Star is always meeting population health and quality goals. You can steal this if you want. I mean, this is our challenge, right? Our challenge is our system incentives on service use savings equals price increases equals slower per capita growth, right? We raise prices, but that growth is still lower. But we can't perfectly attribute patients to hospitals. At the same time, on the operating side, they're like, well, if we have less service use, we need fewer, we need different facilities. And we know that the volumes drive costs. So how do you balance measuring these things in the policy development? This is really that friction of, it's a per capita system, and yet we have to do all of these indirect financial gyrations to make it work when we talk about actually funding the system. Go to the next one. Okay, real quick, and I know James is going to start glaring like fireballs, at me in just a second. The legislative agenda this year, three things that are our topics. This is from an MHA perspective: strengthen our workforce, ensure access, and improve our liability climate. Working day in and day out. These are our priorities, but we are, we're working on other things. Again, key here is to provide incentives to grow the workforce. This is a long-term pipeline issue. And I'll show you that in just a second. We've got to fix the nursing board issues, right? That we're having all kinds of problems that we can't get nurses relicensed and everything else. And that is, we're working on that. And then again, I think, there needs to be some additional state accountability for what we want for our healthcare workforce, particularly as, Katie talked about, the HSCRC's vision and the state's vision to manage total cost of care better. Well, with that comes, changes to the workforce, and what does that look like? And, how are we collectively responsible as a state for doing that? The next one. So we convened a workforce task force. This was chaired by Ed Lovern, who is the CEO of Ascension St. Agnes. And we came up with several, long-term recommendations for policymakers, hospitals, and, what MHA's commitment is to our workforce. You can find these recommendations on our website. We do have the report available, but lots of recommendations for policymakers and for others as well. We, again, need to continue building behavioral health capacity. This is a challenge. I mean, I think you read some of these. I mean, if you read that Banner article about the kids stuck in ED, it just kills you, right? We got to do better than this, and we all have to collectively work to do better than this. We have the incentives. We just need, we all need to work together with the system and how we figure that out. So that is, top of our list. We do want to maintain the telehealth flexibilities. I think this is a key that has been successful and certainly been a key under global budgets, and we need to continue to make this work. I think we may have a statutory challenge on this from a payment perspective that we may need to address in the future. Right now, as long as the PHE is in place, then they've extended that beyond that, which is helpful. I mean, and just the fact we haven't been together in 3 years, think about talk about light years of advancing telehealth right? We went from this to, to incredibly, it's, never let a good crisis go to waste, right? Go to the next slide. Okay, so liability we know is a challenge, and hospital liability. Any trial lawyers in the room? Good. Because that way I may or may not get in trouble. After years of working on this issue, there was a Senate work group around liability, and they come up with recommendations about how we can change this. I think there were different recommendations. Our focus is on improving life care plans. Life care plans is how they determine, what the family gets paid if there is an injury, right? And of course, many of these are birth injuries and are outrageously developed at what, the hundreds of millions of dollars of life care planning will be. And as many of you know, interestingly enough, many of those awards, and I find this fascinating, those awards are actually excluded in assets eligible for Medicaid. So, they may get awarded and then that patient may go right back on Medicaid in certain cases. I always find that fascinating, for those things. But this is going to advance, and I think, we are going to advance this in the General Assembly, and we've had, conversations with leadership and committee leadership, and they are, going to pass something. And they are taking these recommendations very seriously. So after many years, we appear to be getting some traction on this issue. So I think I talked about, many of the things. Katie mentioned the deficit assessment reduction was included in the governor's budget. We'll be working very hard to protect that. A couple other things real quick. We know we're seeing an increase in write-offs from the out-of-pocket costs from commercially insured patients. And we know more and more ire is being directed at hospitals because of that, because that's a contract between the patient and the insurer, and they may not like it, and the employers may be forced to deal with that. But of course, we're stuck, right, trying to enforce that and understand, what our collections are going to be. Because if we don't collect that, it just makes uncompensated care go up, right? And that is the very last thing we want in the system right now, because that will put more pressure on our model test. So we are actively working on those things. Same with, I know many of you, anybody from Medicaid, MDH in the room? Okay. We do know that there are growing Medicaid AR, both the eligibility issues as well as just the slowness in fee-for-service payment. That is something that we are going to take up. Last thing I'll leave you with, I think, Katie talked about this, about what she was interested and proud of about the population health and the investments. I think we are too, as hospital field and as health systems, excited about that. I think we have to work collectively with the commission and CMMI to decide what do they really want as far as population health spending and population health investments. Because I think we know that, right? If we know the rules, we can deliver on that. I think the challenge is, from a regulatory perspective, saying, okay, this is what we want. I think they would rather leave it up to the hospitals. But at the same time, this bleeds back into that routine savings conversation to say, well, are you using it on things that are appropriate, that they may believe are appropriate? If we know what that is, let's understand that. I use the example of both the long-term quality improvement and population health investments versus the savings. Many of you have, extended care management out in the community, right? That is a huge expense, and that has delivered a lot of our savings by keeping people out of the hospital, okay? We only have so many resources. We diverted resources into, we really want to think about longer term, food security and other things. We could do that. And that may ultimately provide a longer success in the future. But if we had to pull money away from those shorter term, care transformation things that may not count, we may not make those savings targets, which are, sort of the more immediate things. So this is a challenge, and we are trying to figure that out. All right, let me stop there. And please, your thoughts, your questions while we're doing.
God help me if I didn't tell him to wrap up 20 minutes ago.
I am 15 minutes over, I'm 18 minutes over, and I started exactly 18 minutes late.
Questions for Brett?
Please, what are your questions? What do you think?
Or comments,
Come on.
or funny jokes.
I didn't even get to my other ones.
We need, I think we need the Martin staff, we need to make these microphones mobile so I can stare at people and make them uncomfortable to ask questions, so we'll adjust that going forward. So any questions for Brett? All right, thank you very much, Brett. All right, so as you may know, we're having some tech issues on the online side, so we're going to take an unscheduled 5 to 10 minute break here. And then Kevin's going to come up from Healthcare for the Homeless. So please come back in 5 to 10 minutes.
Oh, great.
Jeff, hey, how's it going? Oh, what are you talking about?
I will. Well, you guys
I'll send you the Well, I know. You know what you did at this Nothing exciting. Yeah, might be the same. Taking out. Taking out all the sleeves. We'll see. Maybe an hour. I'm kind of fading. Because of the totally venue in the US. I like it. It was good. Yeah, I forgot. No, it's looking at things that bring me. And got to the office, the train. It's probably Alex, Karen. With the train. Feels Okay. Yeah. Well, for the CPAs, they had the Medicaid cost report, which was the way the state facilities, the way they track our missions, I think that's such an educated. But so we had to go downtown and actually verify this chart. Later one day, the stop the wait for BWIA. That's BWIA. I've worked with Brown. Then I was from there. We'll have like 1 or 2 years. What's over here? That's all right. Coming first,
Good morning. Everybody could please have a seat so we can get started.
All right. It's my honor to introduce my friend, Kevin Lindemood, who is with Healthcare for the Homeless. He's the president and CEO, and has been there quite a long time. I've had the pleasure of being involved in that organization, so wanted to make sure that everybody here had the opportunity to hear about what the good things are that are going on with that organization that's kind of in all of our backyards. Kevin just told me he doesn't want me to read his bio, so I'm just going to go ahead and give you what I know. Like I said, he's president and CEO of Healthcare for the Homeless, and will tell you about what the organization does. Came up through social work and is very passionate about making sure that folks perceive housing as healthcare. So I'll let him tell you more about that, but please welcome Kevin Lindemood.
And Aaron, in full disclosure, is one of my bosses, serves on the board of directors of Healthcare for the Homeless, and was active in committee volunteerism prior to that. So we're glad to have him. James, earlier you asked for questions or jokes. I'm a purveyor in bad dad jokes, so I'm warning you. So here you go. Not too long ago, Sylvester Stallone decided that he wanted to do a film about composers. So he gathers together some of his action hero friends, and he said, I'll be Beethoven. And Dwayne "The Rock" Johnson says, all right, I'll be Mozart. And Arnold Schwarzenegger looks at them and says, oh, guys, don't make me say it. Wait a minute. It would be, I'll be Bach. Hi, everybody. I'm Kevin with Healthcare for the Homeless. Yes, hello. I'm probably going to be saying next slide a lot because we don't have a lot of time, and I've got some slides with pictures, so I'll cycle through them. Why don't we go to the next slide? You may know our largest clinical facility. This is our facility along the Fallsway, right as the JFX is coming into the city. We built this building in 2010, and it's our largest and most integrated clinical site. Next slide. You may know us by our mobile clinic that goes out throughout Baltimore City, a little bit into the counties wherever there is need. And there's a mural painted on the side of it that matches the mural on the side of that big building, declaring our belief that everyone deserves to go home. Next slide, please. This is us, Healthcare for the Homeless. And our organization has long shared your goals that we need to address upstream problems, increasingly upstream, in order to avoid downstream costs. And is there anything more tragically downstream in the big picture of things than the persistent realities of homelessness and its deleterious effect upon health? Robert Wood Johnson Foundation started a nationwide demonstration project in 1985. Healthcare for the Homeless was one of 19 projects nationally. And the hospital community was absolutely instrumental in the coalition that put in that grant application. Mercy Medical Center, Johns Hopkins, University of Maryland, among a coalition of about 30 agencies that wrote that grant. 3 years later, Healthcare for the Homeless was incorporated, and the Healthcare for the Homeless program became a national model of the federal Healthcare for the Homeless program. Today, federal Healthcare for the Homeless programs are also, you will know the name, federally qualified health centers, or FQHCs, but many of us remain targeted or special needs from a HRSA designation community health centers. Also from the beginning, our board leadership contained, as it continues to, robust participation from area hospitals, the late Dick Davidson of the Maryland Hospital Association, and then the National Hospital Association, was on our board and an early chair. Cal Pearson, an early chair, as we have grown. Today, from those very modest beginnings, literally a nurse practitioner in 2 different downtown shelters, we're about 240 staff, delivering integrated clinical services, medical care, mental health services, social services, addiction treatment, dental care, targeted HIV, pediatric and adolescent services at 5 different clinic sites. The largest is the one that you saw. We're also on the campus of MedStar Franklin Square in Baltimore County, in one of the county's largest family shelters. We're at the former Bon Secours, now Grace Medical Center in West Baltimore, have a small clinic there. A standalone dental program co-located with the city's largest soup kitchen, Our Daily Bread, and a convalescent care or medical respite care program on top of the city's largest shelter for people leaving hospitals and long-term care facilities who would otherwise go to home care, who literally have no place to go. Policy advocacy, was very interested in the previous presenter and some of MHA's priorities. And increasingly, and this is one of the things I want to talk to you about, we've been a housing developer. And this is after, for years, our board, our senior leadership said, much like federal leaders say in CMS and at HUD, housing is housing and health is health. Housing is housing, health is health. You're a healthcare organization, stay in your lane. And I'll talk about how that started to evolve for us. Next slide, please. Our vision and our mission. These were revised, as Aaron knows well, in our last strategic planning process last year. So we envision a future where everyone is healthy and has a safe home in a just and respectful community. And our mission, working to end homelessness through racially equitable healthcare, housing and advocacy. And this is important, in partnership with those of us who have experienced it. 6 members of our board of directors are people with the lived experience of homelessness. The large majority of them actual clients of the organization. Next slide, please. When we started in the 80s, much of the world, one could say that contemporary homelessness in the US reemerged in the late 70s and early 80s, not seen since the Great Depression before it. Much of the focus was on what's wrong with people that they're experiencing homelessness. What we've really come to learn, and what public policy has been starting to recognize, is that it's structures and systems that are producing homelessness. And indeed, homelessness is far more about those structures and systems than it is about individual personal failings, which I don't know about the last time that you went to your primary care provider. We've all got our own individual personal failings. When it comes to the structures that produce homelessness as what's become a kind of institution is absolutely deleterious to health. So if we look at the frame of homelessness and poverty, healthcare system failures, the incredible lack of affordable housing, and not just the lack of it, but the deliberate disinvestment in housing over the last 40 years. Insufficient incomes that haven't kept pace with the rising cost of housing. In no jurisdiction today can someone earning a household earning the prevailing minimum wage. So that's either the federal minimum wage of $7.25 or whatever localities have done, $12.50, $15. In no jurisdiction can someone earning that wage afford a 2-bedroom apartment. And that is a structural reality that also has continued over the last 40 to 50 years. And of course, racism and racial inequity. We'll talk a little bit about that. Next slide, please. Let's look a little bit at healthcare conditions. You may generally recognize some of these. Diabetes, hypertension, heart attack, HIV, hepatitis C, depression, substance abuse disorder. Let's go to the next slide. That's among those who are housed. And this is from a HRSA and National Healthcare for the Homeless Council review of healthcare for the homeless center patients. You see just people experiencing the same challenges that the general population does, but at increased rates. Diabetes at more than 18%, hypertension well over half of those that we work with, heart attack, HIV, depression, substance abuse disorder. Next slide. As I mentioned before, homelessness is deeply rooted in inequity. The photo here is Dr. Wendy Shaya from the School of Social Work, who's been doing a lot of work on what she calls socially engineered trauma. But in the state of Maryland, people who are Black or African American make up about 29% of the population, but almost 60% of those who experience homelessness in our state. On a national level, it's even more pronounced. People who are Black or African American make up somewhere between 12 and 13% of the US population, but 40% of those in the United States who experience homelessness. One other population in the US more overrepresented than that relative to their population size. Any guesses?
The LGBT plus population.
You're probably right. Yes, you're probably right. Yes, service needs not sufficiently met, but the Native American population far more overrepresented. Was just talking to some leaders in South Dakota, and yeah. Next slide, please. We also know that place matters. I think everyone in this room knows this. Where you live matters, right? The average life expectancy in some of Maryland's wealthiest areas at roughly 82 years, dropping to 68, sometimes just a mile or two or even less away in a different block in some of the most segregated communities in Baltimore City. Among those experiencing homelessness, life expectancy even lower than that. This comes out of a study and literature review that first was done decades ago by a guy named Dr. Jim O'Connell. You might have seen recently on the front page of the New York Times Magazine, an interview with Jim O'Connell done by Tracy Kidder. There's a book called Rough Sleepers that's just come out. Jim O'Connell was the founder of the Healthcare for the Homeless program in Boston. And his early work showed that people experiencing homelessness are 3 to 4 times more likely to die prematurely than their house counterparts due to the presence of acute and chronic medical conditions and lack of access to healthcare. That study was redone with an actual, not just a literature review, but a longitudinal study in Boston just before the pandemic. That percentage, 3 to 4 times, held up for those in shelter. For those living on the streets, up to 10 times more likely to die prematurely. The early phrase in the nation around the healthcare for the homeless movement in the 1980s was homelessness is hazardous to your health. We know that it's absolutely deleterious to your health. Next slide, please. Well, actually, can you go back to the previous one? Go back to the previous one more, the other way. No, back. I mentioned our board really kept us in our healthcare lane, right? But in 2005, there was a park. Some of you were nodding when I mentioned the Jones Falls Expressway. You come down, you see healthcare for the homeless. You get to the end of it, you see St. Vincent's Church. There was a large park there where there was a semi-permanent encampment in 2005. And then Mayor O'Malley wanted to sweep people out. And we said, well, if you do that, it's going to be harder for us to serve them. If you just move people to another block, what have you really done? And he said, what's your bright idea? We didn't really have a bright idea. However, there was a lot of talk about movement from this housing readiness, this focus on what's wrong with people, to this focus on what's wrong with systems, and a paradigmatic shift really from housing readiness to housing first. And we said, why don't you give us 30 housing vouchers? We'll commit some of our social workers. Let's move people into housing, give them intensive services. Now, we said we're going to move 30 people out of the park and 60 more are going to move in, and that in fact happened. But we moved 30 people out. A couple of families were in that mix. 1 year later, something studied by the University of Maryland School of Pharmacy at the time found that everyone was still housed and their health had improved. And that served as the basis for our growing Housing First or permanent supportive housing program. We've got more than 500 households, more than 650 people, a combination of individuals and families, mostly scattered site, long-term, doing what's necessary to keep people in housing. Two big questions, especially I know there's a lot of folks from financial backgrounds in the room. How do you sustain it? Two things. You got to figure out how to make the housing affordable. Housing vouchers, subsidizing housing in the private market, building housing that's permanently affordable, some kind of way. You have to figure that out. And then you also have to figure out how to sustain the supportive services, the social work services, the peer leaders, the checking someone and making sure they know how to get to a grocery store if it's nearby. All of those services, think about how many services you need. Think about how many I need to stay stably housed. My goodness, if I didn't have a spouse and if I couldn't call and pay for any number of things, how do you maintain that household, right? So that's the second part of that equation. Now let's go to the next slide, because this began to shift then as we saw the success of our permanent supportive housing work. And as we saw, as people doing this in other parts of the country as well, started seeing lowered external costs because of placement in housing, a group called Episcopal Housing Corporation, an executive director by the name of Dan McCarthy, came and said, healthcare for the homeless. You're doing this supportive work in housing. We want to build a 12-unit development. We want you to build this, be the service provider for it. So we were going through strategic planning as ourselves as an organization. We asked that housing and health question, and we answered it differently. We said, wait a minute, housing is healthcare in a very real sense. And so this was built, 12 units in the Upton community. We placed 12 individuals who met the federal definition of so-called chronic homelessness, which is a complicated HUD definition. It's essentially someone who has extremely high healthcare needs. Everyone in this particular program is also a Medicaid participant and participating in something that I'll talk about in a moment. This was done. It was done effectively. We're sustaining it. Episcopal Housing came back to us a couple years later. Next slide, please. And they said, we want to build a low-income housing tax credit development. We're going to have some artist housing. We're going to have some market rate housing. This is 2 blocks north of Lexington Market, for those of you who know your Baltimore City geography. And we want to include 20 units. We want to get vouchers for them, and we want you to place people in and continue this partnership. So we said, okay, let's do that. And so 410 Lofts came about. Healthcare for the Homeless is the service provider. Now, throughout all of this, we took a delegation, including Episcopal Housing, out to Denver. There's a group called the Colorado Coalition for the Homeless. It's a healthcare for the homeless program that's also developed 2,500 units of permanent supportive housing over the last 25, 30 years. And we looked at what they did. On the plane ride out there, Episcopal Housing's Dan McCarthy is sitting next to me and says, Kevin, you can never finance supportive services out of a development deal for housing. On the way back from Denver, Dan said, Kevin, we can finance supportive services out of the development deals. Because that's exactly what Denver was doing. Next slide, please. And so we collaborated together and just opened last year Sojourner Place at Oliver. It's in the Oliver community. What's everything way in the distance of this photo? Do you know? Hospital folks in the room. That's Johns Hopkins. Yeah, it's about a mile from Johns Hopkins, and it's about a mile from our Fallsway Clinic, kind of in a triangle. 70 apartments. Go to the next slide. half of them for families and individuals exiting homelessness, half of them affordable at 50% of area income or below, highly affordable. Nothing more than 1,000. I think we're at $750 for a 1-bedroom, $880 for a 2, and $990 for a 3. When we did a lease-up event at a church just around the corner, 250 people showed up at 8:30 in the morning for 35 slots. The need for quality, affordable housing is just absolutely incredible. Next slide. So let's talk about the other side of that equation. With that low-income housing tax credit process, now it took 3 years to develop and build, but we're experimenting with a sustainability model for the services, right? That's what's really significant about it. We're not going to end homelessness with 70 units of housing, but how can we do other things like this that build in the support for supportive services right into the project? Another way to do that is through Medicaid. Now, for a long time, communities have asked for waivers to let it build housing. And as I was saying before, housing is housing, health is health. No, waiver denied. The state of New York asked so many times that it started spending state-only Medicaid dollars anyway to build housing. Why? Because they knew it was effective, right? So around 2015, CMS puts out guidance to states. Maryland was actually pretty early innovator in this area. It's starting to get left behind now. There's 17 active programs or pilots that are looking at tenancy services, so services in housing to keep vulnerable populations stably housed. There's 4 others that are about to do it. They're negotiating right now with CMS, and there's 5 others that are in the planning stages. The Corporation for Supportive Housing has a wonderful report on this. You'll find it on their website. I'm happy to send it to you as well. But you will note that Maryland is in the states that have one. Let's go to the next slide. We have something called Assistance in Community Integration Services, or ACES. The colloquial, the way we refer to it in general is the Medicaid supportive housing waiver. It started as a very small pilot. The Hogan administration applied for it. They said, we're not going to put any state money in it. So localities, Baltimore City, Prince George's, Montgomery, Cecil, you folks that have been asking about it, you come up with the state match and we'll draw down the federal dollars, right? And so with incredible thanks to, I have to give a shout out to Redonda Miller from Johns Hopkins, Dr. Miller and Dr. Mohan Suntha from University of Maryland. It was really Dr. Miller that got all of the hospitals in Baltimore together and had been doing that already, right? As we all know, been trying, how do we get more and more and more upstream? And every hospital in Baltimore invested in the local match for Baltimore to house 200 households. Healthcare for the Homeless was the service provider. And in retrospect now, it sounds really easy. We're at 200. It was ramping that up, identifying the housing, getting to the place where we could do it. But 200 households stably housed. The federal government has just authorized an expansion to 900 slots. And Baltimore City has another 100. So we're poised to go from 200 to 300. The Hilltop Institute is doing a longitudinal study of this. That report, I used to, 5 years ago, I would say the report's due out in 2023 and people's eyes would glaze over. The report's due out in 2023. I understand that the preliminary data is good. But within the next couple of months, we'll be seeing collectively the Hilltop Institute's longitudinal study of the Medicaid supportive housing waiver pilot. The data is good because the feds already authorized it for another 5 years. They wouldn't have done that if they didn't see that there was strong data. We, very anxious and kind of, the Hilltop Institute doesn't want people messing with their data. we started looking at CRISP data. It's imperfect, but we have clean data for 107 of those participants, 1 full year prior to placement in housing, 1 full year after placement in housing. Let's go to the next slide. 52% reduction in hospital visits, 18% reduction in the number of people that even went to the hospital before versus after. 60% decrease in emergency department visits, decrease at 53 in inpatient admissions, 77% decrease in hospital readmissions within 30 days. 41% reduction in charges. What do you see there? You see services falling, costs falling, but not quite as much, right? And you don't see costs falling in the very beginning because we're talking about an extremely ill population. Reference those earlier slides, right? 3 and 4 times the rates of illness as the general population. But over time, you see those costs go down and down and down. We did a lit review when we were trying to get the hospitals on board in 2017, 2018. Same data all over the country, varying, but well within the range. Some better, some not quite as good, but ranging from 40, 50 people to 800 people in some areas. Most of those areas involving hospital support. Next slide, please. We also saw reductions in hospitalizations related to these things, and this is pretty striking. Alcohol use disorders, COPD, COVID-19, and depression. Year before, year after. Next slide. I'll end with a couple of state achievements and some what I see as some opportunities. The telehealth opportunity that MHA was just talking about. Yes, we have to make some of these flexibilities permanent. Yes, in some instances, phone-only telehealth. It kept some of our patients connected and safe throughout these past 3 years. The ability to do that. These were achieved last year. Full adult dental benefit in Medicaid for the first time in decades. Implemented January 1. Hugely important to those that we serve. Medicaid coverage of pregnant people during pregnancy and 1 year postpartum, regardless of immigration status. Also extremely huge. We're in the process of launching OB services at our Fallsway Clinic for the first time in person. We've done it by referral up until now, but last year, 54% of our clients were women. That demographic has changed dramatically. Back this year, there will be bills to extend Medicaid coverage to all who are income eligible regardless of immigration status. And I didn't think we would possibly achieve that other thing. I don't rule this one out, given the climate of Annapolis at the moment. We've got an opportunity to expand the ACES program, the supportive housing program, and could really use all of your advocacy on this behalf. The hospitals in Baltimore are continuing to be supportive. They're also starting to say, hey, it's a pilot. State's got to take this over, right? It would be about $7 million in state funds to draw down a total of $14 million in total program funds to maintain the current statewide program and expand it. We believe that's pretty modest. We understand that it was not in the budget that was just released, but we understand that there's active conversations about a supplemental. We think this is low-hanging fruit, not only for the administration, but for the hospital partnership that launched this pilot 5 years ago. There's new leadership in housing. The new Mayor Jake Day, the new head of the Department of Housing and Community Development, launched a permanent supportive housing program. Understands housing first. That's very exciting. New leadership at the health department and Dr. Laura Herrera, who understands homelessness and health. I think as the entire system is talking about opportunities for greater investment in population health and in moving further and further upstream. And I know there are lots of challenges with doing that, but to realize in the longer term cost reductions downstream. Next slide. I'll end with that. It has been a pleasure to spend time with you this morning. Happy to answer any questions you might have, or we can exchange information, and pleased to follow up in the future.
I'm so sure. Thank you. So we have a question online. How do these affordable housing initiatives take into account transportation? Transportation can be a huge barrier to access resources such as healthcare.
You bet. Transportation is a big issue. Access to food is a big issue. It's one of the challenges that in the area where we just built, it's in a bit of a food desert. There's some broader work trying to change that. We work to make sure when we're identifying sites that they are on routes of public transportation. As I mentioned, it's about a mile from our Fallsway Clinic, where a lot of the individuals we serve continue to get access to care. We as an organization do a lot with bus passes. A lot of the people that we're working with in housing have disabilities, and so we make sure that they get disability bus passes or access to tokens if they need it. Work to medical appointments through rideshare services. Ubers and Lyfts have become sometimes an uncomfortably high line item on our on our financial reports. Always have to keep those in check. But yes, transportation is absolutely huge, as are access to the resources that people need: food, healthcare, access to broader participation in communities. Right? We're not just putting people in housing and leaving them there. We're trying to create healthy and sustainable communities. That's how we all thrive.
Great. Well, thank you very much, Kevin, for your time. It's so important to have our connection to our community organizations. So I'm sure, Kevin, if you have a question coming out of it, I'm sure you can snag them on the way out. We are quite a bit behind this, so we are trying to catch up because I know you all don't want to skip lunch.
Good morning. Good morning.
Good morning.
My name is Tanisha Richards-Brooks, and I have the pleasure of introducing Dr. Jeff Doherty. He is a Deputy Director at the Maryland Health Services Cost Review Commission, where he leads the agency's efforts to measure and incentivize population health improvements on the state cost of care model. He led the HSCRC efforts to develop the nation's first program, providing hospitals with financial rewards to reduce socioeconomic disparities in inpatient readmissions. Concurrently, he serves as an associate faculty in epidemiology at the Johns Hopkins Bloomberg School of Public Health. You do a lot. Pursuing a research agenda focusing on measurement of structural racism and understanding the relationship between structural racism and health outcomes. Before the HSCRC, Dr. Jeff Doherty previously served as the Director of Health Services Research at the U.S. News and World Report, where he led the development of hospital quality metrics. He earned an MPH and PhD in epidemiology from the Johns Hopkins Bloomberg School of Health. Please help me welcome my colleague, Dr. Jeff Doherty.
Morning. So on my way over, I was chiding myself for not having prepared as much as I usually like to for this conversation. But it turns out that I'm actually super well prepared because somebody told me a great joke the other night. So here we go. It's also a question, so I think I get like double credit for that. So what are bears without the bees? Ears. Yep, ears. Okay, next slide. So, all right. Anyway, here we go. Today I'm going to give you a little bit of background on something that we affectionately know as SIHIS, which is the Statewide Integrated Health Improvement Strategy. We'll talk about the development of the Readmissions Disparity Program, which is one of the goals under SIHIS. We'll talk a little bit about our thoughts on expanding some of that disparity work into other hospital quality programs. And then finally, we'll take a look at SIHIS and health equity performance up to date. Next slide. I want to say in advance that some of this is work that I was deeply involved in and led. Other pieces of it were led by others who were generous enough to lend me their slides for the day. So particularly wanted to call out Allison Schuster, Princess Collins, and Aaron Sherman. Thanks for that, guys. Next slide. Okay, so SIHIS, what is it? SIHIS is designed to engage state agencies and private sector partners to collaborate and invest in improving health, address disparities, and reduce costs for Marylanders. CMMI approved our SIHIS goals in 2021. I was thinking about this the other day, and just the genesis of SIHIS is really interesting. So this developed shortly after the implementation of the total cost of care model, and there was a feeling that maybe we had not been sufficiently ambitious enough in setting the financial targets for the model. So the question became, what else can we do to kind of leverage the strength of the model and demonstrate its success, since we're all hitting our financial targets. And so this was a program that developed in response to that question. Of course, I think there's some questions about whether that's a relevant question at this point, because obviously the financial picture has changed, but we're still really committed to seeing success under the SIHIS goals, and I think we're making some good progress there that I'll tell you about over the course of this talk. So SIHIS is a focus on hospital quality, total population health, and care transformation, and kind of the confluence of those three domains. Next slide. So this is the readmission disparities program that we developed and how that fits into SIHIS. And so I'll talk a little bit about the development of that. Next slide. First of all, why is health equity important? There's huge costs associated with health inequity, as well as lost productivity and personal impacts for disadvantaged populations. Disparities also limit the overall progress toward model goals, and increasingly are a priority for CMMI. So that's all driving us toward doing something about disparities. Next slide. Next slide. And next slide. Yeah. No, we're going in the wrong direction. Keep going. Yeah, that's also in the wrong direction. Other way. Keep going, keep going, keep going, keep going. Yeah, there we go. Okay. So when we think about health disparities, I wanted to just underline the point that disparities arise out of a number of factors that occur at different levels in society. They can be an artifact or a result of national policies and environment, stuff that's happening on the state level, stuff that's happening on the local and county level, and stuff that's happening within the hospital. And when we developed this policy, we wanted to be really explicit about trying to target stuff that hospitals have control over. So it's really those top two things shaded in green, rather than trying to hold folks responsible for stuff that's going on in the broader context around them. Next slide. Go ahead and skip this. Next one. Okay, so this is the motivation for this work at the HSCRC, and what this is looking at is differences in readmission rates by race and by Medicaid coverage, which is often thought of as a proxy for poverty. And so you can see that the readmission risk is elevated for Blacks and also for people who are on Medicaid, and so that's primarily what we are trying to address with this policy. Go ahead and hit the next slide. So we're talking about the development of the work, but I will say, just for clarity's sake, that this is work that was done a couple of years ago. The commission approved the addition of this policy to the RRIP in March 2020. And the basic idea is that it looks at disparities from a base year of 2018 and sets some performance goals over 8 years, and the implementation in policy of this program makes us the first state in the country to provide hospitals with financial incentives to reduce disparities in quality of care. Next slide. Next one. Okay, so when we set out to do this and we're thinking about reducing disparities, the question became, what kind of disparities are we thinking of? What sorts of social determinants of health do we want to try to address, and how do we want to address them? there's an issue of whether we want to, if we want to address multiple determinants, do we want to do that with separate measures? So we're providing hospitals with incentives to reduce disparities by race, by income, by neighborhood poverty, things like that? Or do we want to try to create one single measure of exposure to social determinants of health? The trade-off there is that if you do it separately, it's very clear what's giving rise to the disparities, but it can complicate the reporting and the policy development. If you create a composite measure of social exposures, the methodology is a little complicated, but it simplifies the reporting and the policy. So we ended up going in the direction of a composite after talking that over with stakeholders. Next slide. We were limited in this work by the availability of social determinants data in claims. We needed to know that we could understand social exposures for each person who was in the readmissions denominator for the quality program. So we really needed data coverage for everybody, and that's pretty much only available in claims. So the stuff that was available to us was race and ethnicity, payer, and the area deprivation index, which is a multi-item composite of essentially neighborhood disadvantage. Next slide. So here's how we put all that together into a single measure. We basically took those things and regressed against them readmission risk. We used the combined effects, a little statistical magic there to effectively measure the joint effect of Medicaid status, race, and ADI on readmissions. And we, for each individual, effectively predicted that person's readmission risk based on those social factors. And then that calculation becomes a person's patient adversity index score, which is used to measure their level of social exposure. Next slide. And this is just how that calculation plays out. So on the x-axis on the bottom here is ADI, and on the y-axis running top to bottom is readmission risk. And so you can see that there's a pretty good gradient in readmission risk across these unique combinations of race and Medicaid coverage. They all go up with increasing ADI, but the levels are a little bit different. Next slide. One thing that was really important to us in developing this was to do a sort of sanity check, and the policy wouldn't make a ton of sense if some hospitals were only serving patients at very high levels of ADI, and some hospitals were only serving patients at very low levels of ADI. And so what we did here was we looked at the distribution of ADI at two very different hospitals. The one on the right is suburban in Montgomery County outside of DC. The one on the left is, you can tell that we did this a couple years ago because it's Bon Secours, some of you may remember it fondly. So basically what we're seeing here is that these distributions are really different, right? They couldn't be more different. And that's as expected, but the takeaway is that even though the distributions are different, the coverage across the range of the patient adversity index is pretty much the same for both hospitals. So in other words, even though Bon Secours served a really challenged community, they still had people at both ends of the pie distribution. Even though suburban serves a really affluent community, they still have people at both ends of the pie distribution. And so that was really encouraging to us in developing this. Next slide. Yes. Yeah. So once we developed this index, we then needed to understand the relationship between the index and readmission risk. And this slide is sort of a detailed way of saying that what we ended up with was putting this into a statistical model that did a couple of things for us. One, it allowed us to adjust for patient characteristics, such as patient acuity, age, gender, that sort of thing. It allowed us to apply some statistical magic that accounted for small cell sizes in some cases. So hospitals that may have only a few people at the very far reaches of pie at one end or the other, we can still get pretty good visibility on their performance because of the features of this particular model. And it allows us to eliminate the effect of disparities external to the hospital. So we're effectively adjusting for the average patient adversity index at the hospital, and then understanding only the difference in readmission risk that occurs at the hospital. Next slide. And so go ahead and skip this one and the next one. And then, yeah, so we'll just talk about all this right here. So this is a tale of two hospitals, if you will, Hospital A in green, Hospital B in blue. And you can see that they have a bunch of, these are patients that are the dots that are kind of aggregated together in big blobs. And basically what this is saying is that Hospital A has a lot more patients at the upper end of the patient adversity index because they've got more coverage up there got more blobs up there on the right. Hospital B in blue has fewer patients up there on the higher end of pie because they've got fewer dots up that way, basically. If you look at this, the disparity is basically the slope of this line because this graph describes effectively the relationship between the patient adversity index and readmission risk, right? So a little thought experiment. If you had a line that was horizontal at 12% readmissions, that would mean that there was no impact of social factors that we're measuring on readmission risk, which would mean that there's no disparity at that particular hospital, which is ultimately the goal. That's not the case for any of the data that we have yet, but we definitely want to move in that direction. So in any case, the question would be, your Hospital B, you don't have any patients hardly at the upper end of this, so is that a concern? And the answer is really no, because what we're measuring here is the slope of the line. It doesn't matter that there's missing data at the top. And then the other question is, well, I'm Hospital B, how do I know that I've improved on disparities? And basically that's the red line below there, which would be Hospital B has been successful in flattening the slope of that line, which means that social factors are having a less significant effect on readmission risk. Okay, so a couple points to incorporate this into payment policy. One is we wanted to be fairly consistent with the existing readmission policy and other quality policies. RIP provides rewards of up to one patient, inpatient revenue, penalties of 2%. And we wanted to size the disparity component appropriately to reflect the importance of the issue, encourage movement, but also we didn't want to swamp the overall RIP program with the disparities issue. And we needed to provide a preset target and scale to provide hospitals with the ability to assess potential ROI for programs that target disparities. Next slide. So currently for rate year 24, this is what we have in policy. The policy is importantly reward only, and we are kind of continually evaluating that, but have no immediate plans to put this into a reward and penalty status at this point. It requires overall readmission improvement for eligibility. We didn't want a situation where hospitals could get rewarded for narrowing the gap by basically making readmission risk worse for people at the lower end of the pie scale. So we require an overall improvement. Rewards are scaled at 0.25% of IP revenue for hospitals on track for a 50% reduction in disparities over 8 years. And then they bump up to a max of a 0.5%. For folks that are on pace for 75% or larger improvement over 8 years. Next slide. And so we'll talk about where performance sits on that at the end when we talk about the overall science performance. So we are currently talking about extending this work that we've done on readmissions into other quality programs to get some visibility and incentives on disparities there. And so we are looking at the possibility, or we have looked at the possibility of doing this for the payment, 14 payment PPCs in hospital complications, inpatient mortality, and our timely follow-up measure. Next slide. So we'll talk about timely follow-up first. Really briefly, the timely follow-up focuses on whether people who are admitted for a handful of specific clinical conditions have clinically appropriate follow-up within a certain amount of time. It's 5% of the total QBR score for that quality program. Go ahead and next slide. Okay. So we evaluated this by putting a couple of pieces of social information into a model that's adjusted for age and sex. We looked at this from calendar year 18 to 21 using the Medicare data set. We have better follow-up data for Medicare than we do for other folks, so that's why we did it there. Next slide. And so what you're looking at here is the risk of poor follow-up by race on the left and by dual eligibility status, i.e. Medicaid eligibility on the right. The takeaway from this is that you can see that for Blacks and Hispanics, there is an elevated risk of poor follow-up. And there's also an elevated risk of poor follow-up for folks that are eligible for Medicaid coverage within Medicare. So both of those are concerning evidence of disparities, I would say. Next slide. This is looking at the same thing by deciles of the area deprivation index. And you can see that there is an increasing relationship between poor follow-up and ADI, which is also evidence of a disparity there. Next slide. So we also looked at this for the PPCs, and I'll go through these pretty quickly to try and make up a little time. The disparities for PPCs and inpatient mortality were either non-existent or not as pronounced as they were for readmissions and for timely follow-up. Next slide. You can see the same stuff by payer, which is largely following the same trend. Next slide. And then this is looking at ADI, which I think at best could be described as a fairly confusing relationship there. So here's where we look at current performance on disparities and the other SIHIS work. So goal number one, reduce avoidable admissions. We actually outperformed this significantly for 2021, which was the first milestone year for SIHIS. So the goal was 8% improvement. We actually hit 25% improvement, which is a little bit better than the goal for the entire model term. So that is super encouraging. Definitely a high point, I think, in this work. Also, looking at the right-hand panel on this, looking at the readmission results for disparities. The goal for 2021 was to establish this measurement approach and get something into payment policy. So we were successful in meeting that milestone. Later on, so this year, the year 5 target would be having half of the eligible hospitals achieving 25% improvement in disparity, and then the end of the model is to get half achieving a 50% improvement in disparity. We're not quite on pace to get that, to hit that this, as of last year, to hit that this year. So we had 10 hospitals that are on track to meet the 2028 target, which is fantastic performance. Some of this, both the measurement and I think the disparities work at hospitals has really been complicated because of COVID. So we're hoping that that picture becomes clearer and more straightforward as the really intense piece of the pandemic is a little bit further behind us. Next slide. So looking at care transformation, one of the key metrics here is just the percentage of total cost of care dollars that are under care transformation. So for 2021, the milestone was to have about 12% of Medicare TCOC under the CTI or CRP or their successor models. And so we hit that pretty nicely, which is great. And then you can see the targets there for the rest of the model, which we're well on track to hit. And then timely follow-up after acute exacerbations. The goal in 2021 was about 72%, 2% improvement. So we did meet the milestone there, which is unfortunate, but I think also has a lot to do with where we stand vis-a-vis COVID. And then you can see the target down there for the end of the model at the end. Next one. I think this, I'll skip a couple of these slides in the interest of doing my part to get us sort of back on schedule, but you'll see these, and this is essentially the CRISP CRS dashboard for SIHIS, and so any of you who have access to that can see this material there. It's essentially just tracking how we're performing on some proxy measures. Next slide. And that's again CRS that you guys can take a look at. And the next one. Yeah. And so in terms of maternal and child health, one of the goals is to reduce the severe maternal morbidity rates. This proved to be a little bit of a challenge for us, this proved to be a successful one in 2021. And then you can see the goals for 23 and 28 are further improvements in the maternal morbidity rate. And then the goal on the right panel for childhood asthma is again to reduce the frequency of emergency department visits. And so we've got stage goals for 21, 23, and 28 for that as well. Next slide. And so there's the asthma trend. And again, because it's ED focused, this is monthly reporting. It's pretty tough month by month with especially COVID to understand what's going on, but that's what that looks like. Next slide. Yep, there we go. Okay, how'd I do? Not so bad. Okay, we'd love to take a question or two if we have time.
This working? There we go. Question. Jeff, what other opportunities do we have to incorporate race, ethnicity data into what we're doing with the payment models? Maybe beyond outcomes into other areas of the model, do you think?
Yeah, that's an interesting question. I think this stuff is really it's really helpful to think about process of care when you think about this, because ultimately disparities are seen in the outcomes, but really the question then becomes, well, what's happening upstream of that outcome, right? That is leading to that. So I think sometimes our visibility on that information is not great just because of the data sources that we have access to. But I think that it's definitely interesting to think about how we can start to look at some of that stuff, but also at the hospital level, to really understand the delta in process measures between people of varying racial groups, people who have different levels of poverty, things like that. I think it's also really important to start thinking about how to collect data on social factors in a much more meaningful way. And so the Z codes that have been developed in ICD-10 are helpful in that regard, but in my mind, at least, could go a lot further in that the Z codes, you're asking about whether somebody has currently an issue with homelessness, currently an issue with unemployment. But as we all know, with social factors, it's basically race, class, education, income that are driving all of these things. And so I may be temporarily housed or employed, but if I'm on one particular end of the scale for those factors that I just mentioned, I may be very well in and out of housing, employment, and all those other things. So really capturing those social dynamics, I think, with much more kind of demographically based questions might be really important. Is that helpful?
Yeah, so very much so. Other questions for Jeff? All right, well, in the spirit of continuing to get back on track, Jeff, will you be around for a little bit longer?
Sure.
So if you have questions, grab them, and we'll get rolling to our next speaker. But thank you very much, Jeff, for your insights.
Thanks.
And great job getting us back on track. Sort of.
All right. Good morning again. I have the honor this time of introducing my colleagues at Care First. Maria Schweitzer joined Care First in January of 2022 as a Network Capacity Program Manager. In this role, Maria develops and leads a new program of analysis and reporting to make data-driven decisions across all networks, influence contracting decisions, and facilitate a collaborative approach with our provider partners. After receiving her Master's in Business Administration at the University of North Carolina Keenan Flagler Business School, Maria began her professional career in healthcare as a business change manager focused on the small group and individual market segment in Virginia. Prior to her current position, Ms. Schweitzer also worked overseas as a consultant for international clients in the insurance industry. And alongside Maria will be Katie Doyle. Katie Doyle joined Care First in March of 2012 as an intern right out of college and has been with the organization ever since. Katie currently works as a lead data analyst. In this role, she is responsible for collecting, cleansing, and interpreting data sets in order to solve problems. Her experience at Care First has led to her developing the methodologies for Care First specialist cost efficiency scores and profile scores. Katie graduated from the University of Maryland with a bachelor's in economics. Go Terps. All you.
Hi, we'll try to make this fast because I know everybody's probably thinking about what they're gonna have for lunch, right? And no bad mom jokes for me. Okay, so I'll be talking to you today about our capacity program at Care First, and we'll be walking through a case study to show how the practical application of the program can be applied. Okay, next slide, please. All right, so we're gonna start off with an overview, talk a little bit about what exactly is capacity planning, what are some of the foundational concepts of the program, how we apply it to access frameworks, our care delivery, and then as I said, Katie and I will walk through a case study, and then wrap up with a summary and some Q&A. Next slide. Okay. So what is network capacity planning? So in the simplest terms, it's really trying to answer the questions, what sort of healthcare do we need in a given geography? The other important components of the program are really making sure that we try to assess those access needs in collaboration with our provider partners. And then the other important component is to make sure that we're making data-driven decisions. So these aren't decisions that we are making just by our assessment of the market. We're really doing data analysis to determine what we need in access and where we need it. Okay, next slide. Okay, so in terms of some of the foundational concepts for capacity planning, a lot of those concepts we borrowed from the urban planning discipline. And so when we're thinking about healthcare network planning in terms of strategic network planning, we're thinking about setting high-level goals for access and determining areas of high growth and need. When we're thinking about facility use planning, we're thinking about ensuring the right type of care access and the right geographical settings. And we're thinking about sustainable planning, we're thinking about creating development of a network that maintains adequate supply without inducing artificial demand. And when we're thinking about economic development, we're thinking about investing in a provider network and our partners to produce value and outcomes for our communities. All right, so at the foundation of the capacity program is really how we look at access and how we define access for our members as a company. And so you can tell by this slide, there are quite a number of factors that we think about when we think about what contributes to our members' level of access as well as their patient experience. So there are a number of factors that we take into consideration. And so for us, how we really define access is really the member's ability to identify and receive the right type of affordable care at a high level of quality in a delivery format and location that reflects the member's health and socioeconomic needs within a reasonable time period and within our network of providers. Okay, next. So thinking about that definition of access that I just shared with you and all the various components that go into how a member experiences their healthcare needs being met, we then apply those same different components to building out access frameworks for the various healthcare specialties. And so this is an example of what we built out for the behavioral health specialty. And so you can see that we're taking into consideration and looking at the various life stage of a member, as well as the level of acuity and type of care that a member might need throughout their lifespan. And we're also considering what are we providing for our members in terms of access. So whether they're able to access providers, or as was mentioned earlier, telehealth resources, or what sort of digital health resources might help them, again, at where they are along this level of acuity and also where they are in their life stage. So using this kind of framework, we're able to then assess, okay, do we have a gap here, and how we might be able to meet that gap and find a solution. Okay, next slide. All right, so in terms of how capacity planning relates to care delivery, our goals in the capacity program are really to ensure adequate capacity, enhance our members' access to quality care. In the case where we do have unnecessary capacity, we want to make sure that we reorient that capacity so that providers don't have the need to generate revenue and offset those expenses. And we want to be able to strengthen our network by contracting for specific care needs and driving desired health outcomes. And always we're keeping the goal of a healthy member or a healthy patient at the center of all of our product development. So those are the goals really of what we're trying to deliver in the capacity planning program. And then how we do it is through a 3-step process of tracking utilization, mapping supply, and then projecting demand. And we're gonna use a case study to show how we use those various steps in the capacity program. Okay, next slide, please. All right, so the case study that we'll talk to you about today is an endocrinology practice that came to us and really wanted to talk to us and get an assessment of where they could build out additional capacity. They are an endocrinology practice which is focused on patients with type 2 diabetes and specifically on those more complex patients. So we're talking about patients who have no A1C data or who have an A1C level over 8. The practice currently has 2 locations. So one is in Baltimore, one is in Arlington. And they were thinking about Washington, D.C. as a 3rd location. But again, they came to us and wanted to make sure that that they were building a location where there was an actual need. So, so we took a look at a number of different factors when we went through an analysis of where would be a good additional location for this practice. And so we looked at supply and demand data that we have for endocrinology. We did that across the geographies that we serve, which are Maryland, Virginia, and DC. We looked at type 2 diabetes by our type 2 diabetes membership. And we also looked at practice data and cost and utilization data. And we'll go into all of these in a little bit more detail in the next slides. Okay. All right, so in terms of what goes behind the supply and demand data that we use, we worked with an outside vendor in order to create these forecasts. And in creating those forecasts, we looked at a number of different data sets. So we used 5 years worth of claims data, provider data, membership enrollment data. We also incorporated state population data from sources such as the U.S. Census Bureau. And we also included the healthcare professions provider population data. Next slide, please. Okay, so then using those different data resources, RTI, which is the 3rd-party vendor that we use to help create these forecasts, they utilize a 4-step process for creating supply forecasts as well as demand forecasts for us. So the first step in developing the supply forecast was really to identify the baseline provider workforce, The second step was calculating the baseline average visits supplied per provider. And then the third step was forecasting the Care First provider workforce over a 10-year period and at five-year increments. And then step 4 was converting the projected Care First provider workforce into projected visit supply for 2020, 25, and 2030. And then for forecasting demand, we did a similar 4-step process. So for step 1 for demand was identifying the baseline Care First member years. Step 2 was calculating the baseline visits demanded per member year. And step 3 was forecasting Care First member years for 2020, 25, and 2030. And step 4 was then converting the projected Care First population into projected visits demanded going out for that 10-year time period. So if you go to the next slide, you'll see how this then translates to the case study that we're discussing today. So you can see here, what you see here is the visit comparison columns, and you can see that that's done on a county level, and then this is specifically for endocrinology. So the visit comparison is really then that difference between the supply forecast and the visit demand forecast that we discussed on the previous slide. And so what you can see in terms of endocrinology, the county that is forecasted to have the highest projected endocrinology visit deficit is Montgomery County. And you can see also that that continues to increase from 2020 to 2030. Carroll County was identified as having the second highest deficit for endocrinology, but you can see that that remains relatively flat when you go out to 2030. And then I included DC just because that was what the provider had initially suggested as placement for the third location. And so you can see that what was forecasted for DC was actually a surplus. So then we did further investigation into Montgomery and Carroll County, and Katie is going to talk to you about what we found with our further analysis on those counties.
Thank you, Maria. Next slide, please. I am going to discuss what we did internally at Care First to evaluate these 2 counties to get us a location recommendation for this endocrinology practice. Care First has a tremendous amount of data at our fingertips that we like to help recommend and work with other practices in order to hopefully create a better experience for our members. So the first thing we did was we looked at our endocrinologists in our credentialing system. We looked at the practitioners, not just the practices, because we wanted to get a holistic picture of all of the doctors that were endocrinologists. We also utilized our Truven medical episode grouper. Some of you may know that as MAGS. We looked at those members that were diagnosed with a type 2 diabetes episode. We did do a little exclusion there. Oftentimes impaired fasting glucose and impaired glucose tolerance are grouped into those type 2 diabetes diagnoses, but we found that oftentimes it's more to do with someone eating before their blood test than it is with an actual diabetes diagnosis. And the third thing we did was pulled all of those medical claims associated with the diabetes episode. So that's not just specifically claims with a diabetes diagnosis, it's all claims related to that experience. Next slide, please. So from the recommendation from RTI, we looked specifically at Montgomery and Carroll counties. We looked at our membership to see where within those counties we had the highest type 2 diabetes members. So any data from now on you see will be specifically for those type 2 diabetes members seeing endocrinology specialists. So obviously Silver Spring has our highest population for Montgomery County, and Westminster has the highest for Carroll County. Next slide. Here we did analysis on our practitioner locations within those 2 counties. We have a total number of practitioners, 26 in Montgomery and 5 in Carroll County. Although Silver Spring is the highest number of has the highest number of Care First members with type 2 diabetes, they have the lowest number of endocrinology practice visits for Care First members in that county, which is an indication that a lot of these members are traveling outside of their immediate area in order to receive those services. Next, yep. Here we have a slide that we call Measures That Matter, MTMs, focusing on some per 1,000 numbers and some PNPM numbers. 2 things to highlight are members with type 2 diabetes in Montgomery County use a greater amount of endocrinology specialist office visit care than members in Carroll County. That's that 373 versus 491 number. And then the cost of endocrinology visits is increasing in Montgomery County, while the cost of endocrinology visits are decreasing year over year in Carroll County. We use these figures to drive our recommendation. You can go to the next slide. Here we have a heat map of our type 2 diabetic members. So that's kind of your heat map is the member population, and then the dots represent the endocrinology practices. The size of the dots reflect the visit volumes. So it's really easy to see kind of across our entire Care First region where the practices are and which practices are being utilized the most. We're going to go to the next slide and drill into Montgomery County. Actually, can you go back one? If you look at the top of the graph, that's where Carroll County is in the middle. There's not a large population, and if you can kind of see the little dot underneath the Carroll, the practice is right in line of where the population lives. Now you go to the next slide. So this is the drill in on Montgomery County. You can see Silver Spring kind of in the center, bottom center. That's kind of our focus because we have a pretty decent population size there, and you can see those 3 little blue dots reflect there are practices, but the practices do not have a high visit volume. One more, and this is a even further drill in on that Silver Spring area with the specific endocrinology practices labeled, and the zip codes are kind of highlighted where the diabetes members are living. Back to you.
All right, so based on our analysis, it was pretty clear to us that Montgomery County was the recommended location for the endocrinology to build out an additional location. And so one of the main reasons being that it has the highest forecasted endocrinology deficits of all the counties across DC, Virginia, and Maryland. And then within Montgomery County, Silver Spring seemed like the obvious choice, given that it has the highest number of members with type 2 diabetes in the county. And then as Katie also pointed out, that it is also the city with the smallest number of endocrinology visits within the county. So our hope is that by building an additional location for the endocrinology practice in Silver Spring, Maryland, that it would ultimately help us realize reduced utilization and cost associated with those complex type 2 diabetic patients. Okay, next slide. So hopefully the case study gave you a good example of how the capacity planning program can work on a practical level and how we're able to really work together with our provider partners to use data to drive network decisions and also guide our contracting decisions and make sure that we're providing all of our members with adequate care and access to high quality care within the community. Okay. And that's it.
We're open for questions.
Open for questions or lunch, whatever you want.
Question, go for it.
Hi, I have a question. You said the endocrinology group came to you, Care First,
Yes,
for this data.
that's right.
Do you ever use analytics yourself to say where are gaps in resources for our covered lives? And then do you initiate, a health system to, or a private physician group to kind of fill those gaps?
Yes, 100%. That is the goal of the program. It works both ways. We ideally want our providers to view us as a partner in building out those additional facilities and also come to us rather than build them out and then come to us on the back end and hope that we actually have an access need there. So the goal is really to start getting the word out and making sure that providers understand that we are there. We want to serve as a team that can really provide that analysis and make a good recommendation. But indicate the other component of the program is also like to examine on a specialty or facility basis, where do we have access gaps? And so we were talking a little bit about that with the access framework. And so when we do identify those gaps, we need to come up with solutions. So sometimes that is going to be going to a partner that we have a good relationship with and we know is delivering a certain level of quality, and approaching them and saying, do you have interest in building a location or building out access in a given area? And sometimes that is going to be a physical location. Sometimes, and this is where, something positive that has come out of the pandemic is that we're able to now look at some more creative ways, whether, depending on the membership in a given geography, maybe it makes more sense to have more of a digital resource or even maybe a part-time resource or a mobile resource or a telehealth resource. So we, I will say, because of the pandemic, we have, I think, become more creative in how we are looking at filling those access gaps. But definitely it goes both ways. The providers can most definitely come to us, but we will also reach out as well.
I got a quick question.
Lots of
I
questions.
think it was kind of hard to see in the back there, but I was
Oh,
curious. It was curious in the, as you're supporting your provider partnerships, and I think it was Carroll County. I was curious while there's obviously an access issue we're focusing on, I think it was the Carroll County piece, cost of admission later for acute admission was almost double what was in Montgomery County. Does that, as we in the room focus on total cost of care, does that come into the question of, okay, the access is of course crucial, but how does that impact ultimately if the patient is, or the member is sick and gets admitted? Is that being thought about in the equation or in the conversation at this juncture?
Oh, we're definitely thinking about the total cost of care, and that is one of the, I think I mentioned it at the sort of recommendation slide, that ideally, and particularly as it relates to diabetes, we want to ideally meet the member, the patient at the beginning stages of disease development, right? So we can catch it and reduce costs from the front end and also improve their health outcomes, right? So I think that's a shared goal really from our perspective and thinking about, Care First as an organization and the health of the member. For sure, we want to make sure that we're providing that access in the initial stages of the disease when it's easier to resolve.
Great, thank you.
Sorry, last one. Got a lot of questions. So it's a good thing, right?
That's okay. We're happy people are excited.
Yeah, I know this might be more of a broader rhetorical question, but
Okay.
with respect to access and in light of all the financial struggles that providers are currently experiencing
Yes.
that we've been talking about today, what concerns do you have with respect to access, especially for physician practices and things that aren't necessarily accretive to the hospital's GBR, and they're looking at can we continue to sustain these things if they're not agreeing with our bottom line? I'm just curious if you have concerns about access.
Oh, we definitely do, and in terms of how it relates to cost of care for other practices, that's something that actually was a conversation this week. And I would say that relates to something that I mentioned just briefly in the presentation in terms of making sure that we're not incentivizing unnecessary capacity, right? So as I said, that was a very specific conversation we had this week because we were in conversation with a group that wanted to add an additional location that according to our analysis, we really didn't see the need for. And so their kind of argument was, well, why not just, let us in the network and then your members can decide whether they want this facility or that facility down the street. And our response was, well, we have to think about, the constraints of the labor force, right? And what is that going to do to the cost of labor? And then ultimately those costs then get transferred down to our members. So that is something we're very much cognizant of, and I would say is probably a big driver for us in terms of making sure that we are not incentivizing any unnecessary capacity in the system.
Thank you. Well, thank you very much.
Okay.
All right, so if your table is a prime number. Oh, wait, no, never mind. Kalita, what did you have for me? You were just waving at me. If your table's a prime number, you can go ahead and grab some lunch. If your table is not a prime number, you can also go grab some lunch. So we're gonna reconvene at 1 o'clock. We're back on time. Thank you for your attention and looking forward to a great conversation in the afternoon as well.
That's why I was making too. I was like, I know it's like there. I was like, man, no. We got some I wouldn't know the TV. I don't know the work. Anyway.
I was after August. I'm still not
Yeah. Yeah, she cut that deep. No, that's. Yeah, I saw that, wasn't sure. I know. Yeah, I know. So far, yeah, I filled out very quickly, but yeah, we're not part of the exact. Oh, really? Yeah, but now it's been good. I really like it. About all that. I'm going to talk to Katie. Okay. She had an initiative to call about mental health for how to stand up. We're actually looking at states down the mall, some other locations up there to find the states, so we're trying to figure it out. We actually have a site. Oh, really? Yeah. Because it would support women and baby and birth, bringing OB stuff to psychiatrists. But yeah, we're trying to figure out where it is. And we're also trying to get some funding too. And it was like one of our Ruben, you know, I mean, might be better value. Right. Yeah.
Excellent.
Easy for me to say. But that play call on the goal line, once it's there, knock it out of the hand and go to the game. Play call, that me too. I got in it. I had like nothing I would do it.
Exactly. And I was like, no excellent. I told myself that it was
would have been less stressful.
Yeah, losing that man is so strange.
And then, you know, if they thought it would win that, which Cincinnati didn't go for.
Oh my goodness, I know. Watching them play.
Yeah. All the wide receivers, they're stacked offensively. And these are just bad. Maybe they would do a whole lot.
Yeah, that's a good point. They got three and two a lot. Pennsylvania.
Call college.
They don't have to pay for it. I don't like watching it. I don't know why. I like it. North Carolina. I'm Maryland.
I keep thinking Maryland's gonna be good at that, then they take a dip, and then that's when like, oh, maybe they run that.
Same thing. I lost the deal.
Yeah, it's great if they would just go on a run and like, you know,
I feel like college.
I don't follow the NBA at all. Just so like one-on-one now.
I might fall for it. Because every time they have a chance, they probably make a trade or something. Get rid of I'll see if they do.
They got a young team, they got huge expectations, yeah, so I'm really looking forward to it. It looks Unfortunately, the owners have kind of built that. Kind of built that there whether
Nothing for a while,
yeah, I've been to Ravens here for a long time. My buddy, family season tickets, but he lives up in New York. He would come down the He's inviting me, but I was always on a Sunday. Rarely, and I rarely watch the game. I'm not kind of 1 o'clock, you know.
Same thing.
My buddy invited me over to the Cincinnati game. It might have been the first time I watched the full game. I would catch like the highlights, I'll catch like one or two. Probably better the way Ravens was playing that like
No, believe me, their size, I go close to
yeah. And the other thing is a whole day event.
Like, you know, so excited, then when they score again, when they lose,
Yeah. Yeah, he still comes down.
Wow.
Although his wife's doing her first in Houston, so he might be in like November, the Carolina game.
Yeah.
He's like, this is probably the last game I'll be going to in a long time. I was like, yeah, enjoy it, buddy.
You know, not all, but maybe we'll get a.
He'll get, maybe he'll get a week off.
They'll get a week off. Yeah, so yeah, no, I think
You guys doing good?
Hey.
how you doing, young lady? Thank you so much.
Yeah, right. May have been working on somebody, may have to look at that.
Oh, you'll like that.
I'm always in the office, I help access to the chairs. I would, yeah. She's always there. On the other side of her office, my boss is senior administrator. So three of us kind of like run the department, so we're always there. To be honest, really separate work. I'll make a double daycare in the morning, and I forget going to school, coming to work. I think email my phone. So I really like that.
I like the fact. So we were home and like I was I go with the we're there, same thing. I feel like it's I don't know, I like this.
Yeah.
So it's nice for my,
Yeah. Where's your office?
The last session starts at 3:30. Used to be the last one was at 4:00. Yeah. It says 8 to 5. The thing outside the door says 4:45. This is Oh, good. maybe they don't see
I saw one of their first and said for private.
yeah, exactly.
But none of the other ones.
Yeah, I know, I thought it was the same thing. And then look like it's not. It's really good. I was looking at the numbers.
Yeah, he had taken them from other people. Yeah. How long have you been on?
That's how it was like,
I think it's because he's the member
He said
today.
that he did.
Yeah. Only next to me how long.
I was out of here waiting. Really just got back that long. I was gonna have trouble, right? Yeah, but it's good for that's a long
Who sit around you? Are they also DSL owners or kind of?
Yeah, it's good. So there's a guy who says he's been in a virgin. It's like, I can see now. So it's good. That's good.
Yeah.
When he get there, he's like, you gotta work. That's his name. So now kind of for the majority, and our section of 518, I'm not sure what it is, right by the door. So like great.
Yeah.
So there's a guy. Yes. So he's on the so like he's the guy. So it's probably about 10 or 15.
Yeah.
I noticed like where we're so so much. So far it's like great. I know 20 minutes is all like everything right there. Okay, you must have bought. I don't remember. No, like I said,
Were you on the wait list?
I didn't do it right away. So outfits are going right. Never really. So they're all like, one of those things like, I could do it. So I remember, I think I just probably transitioned from whoever got called. They give you some knowledge, which is great. So they give you like the 50. This is my budget. So he was like, no, we get that all the time. It was like big.
Everybody
each year. So there is a one.
Like for years, like before you got on the wait.
No. So you're on the wait. And then that'll come
Yes.
So they give it to you. Well, they have. once he goes there, so that's the way he goes. So when it gets better, he can go like this. She's like, I just like going for her body. And she goes to something. After that, like,
Cuts it off.
she cuts it off. But no, you're exactly right. And I'm thinking probably not like a good time.
Yeah.
But yeah, talking to the guys there, but it's interesting to see this with Bob.
Yeah.
I call like the very early out there. He said he's good there. I've never seen it.
Really?
Yeah. I didn't go to the but my sister, she doesn't want to go. That's just another thing. I'm sure. Yeah, but it's a pretty good. It's a pretty good. No, so kind of
yeah, I would say I didn't have part for work. I would have part.
Okay, yeah, same thing. Yeah, so that's what I do. It works out. It works out. Yeah. Some of the, I get about it's pretty cool. It's not really cool. So it's not a bad thing. It works out. But no, but it's the opposite. So you're the same thing.
Right there.
For me, I'm like,
Maybe one day, but that.
Yeah, no,
we got little kids.
Oh, sure.
They got that. Oh, doctors there.
Right by Canyon Yard, actually, on kind of Brad. We're like right, just you know, bank buildings. We're right like there. Yeah.
And that was my,
Yeah, I haven't yet. I've only done, yeah, I've watched a lot of the webinars, yeah, but I think I maxed Right, that's what I see.
Oh, okay. It was so good.
No way up. Oh, no way.
Welcome to. No, so at the time, so we real guys
Like a parking ride, like.
Would Matthew Whiteman please approach the stage? Matthew Whiteman. All right, we're gonna get reconvened here, but we have a quick public service announcement from Matt. But before I yield the mic to him, I wanted to make sure you guys saw this flyer out on the registration table for the annual CFO dinner, which is coming up February 9th at the Center Club, 5:30 at the Center Club in downtown Baltimore. And I pointed out to you because it's a ridiculously awesome panel that we have at that CFO dinner. So Jenny Smith, who's the Executive VP and CFO of Care First, will be on the panel. Brad Chambers, the Senior VP and COO of the Baltimore region for MedStar. And Kevin Sexton, who's currently a consultant but a retired president and CEO of Holy Cross Health. So pretty ridiculous panel coming up for you guys. That session does fill up quick, and there's a capacity constraint at the Center Club. I may be speaking out of turn, but I'm trying to create urgency. So sign up sooner rather than later to go to that great event. But let me turn it over to Matt.
Thank you, sir. So good afternoon, everybody. My name is Matthew Whiteman. I'm Director of Corporate Finance at GBMC. Also serve currently on the board of our Maryland chapter at HPMA. I'm just doing a quick plug for our upcoming event, the William Mooney New Member Conference. Katie and Connor and I are all working on planning this event. It's a fantastic event. The last time we did it was right before COVID. It was a big hit. We got a lot of good feedback. But what it is, it's a half-day event geared towards people that are new to the industry. So whether you're fresh out of college or coming from a different market or transferring from a different industry, you're going to get some good educational content on this Maryland model and what it means. For those that are familiar, it's the content that we used to do in the side room over here during this event. So you get a good overview of the Maryland model, understand the conceptual framework, and then some other good educational materials. And then the real kicker is we have a 2-hour speed mentoring event. So we're shooting for over 20 industry executives. So, high level CFOs, SVPs, finance of the sort will be there offering their time to give you some real personalized career mentorship. It's a great opportunity to meet them, network with them. And even better is this year we'll have some alcoholic beverages afterwards. So we can continue those conversations and hopefully it's going to be a great time. And thanks to KPMG and James for graciously hosting us this year. So the event's on March 23rd. It's about 2 months away. Mark it on the calendars. So if you're a new member, please join us and look for registration to come. And if you're a senior executive and would like to be a mentor, please reach out. So thanks.
All right, good afternoon, everyone. My name is Connor Loda, and I am so excited to introduce our next speaker. Mrs. Katie Eckert is the incoming Vice President of Reimbursement and Strategic Analytics for Adventist Healthcare. Katie most recently served as the Vice President of Strategic Analytics for the Maryland Hospital Association. She led the creation of actionable analytics to advance MHA's advocacy, care transformation, and improvement efforts for Maryland's hospitals and health systems. With more than a decade of experience in healthcare, Katie joined MHA as Vice President of Healthcare Payment in 2019 from Bon Secours Mercy Health, where she served as the Chief Financial Officer, Post-Acute Services, and also led financial operations for the Atlantic Group. There, she oversaw $100 million in post-acute operating revenues for services at 13 agencies and facilities across 5 states. Simultaneously, as the operations finance lead for the Atlantic Group, She was responsible for ensuring expense control and operating profitability for Atlantic Group. She previously served as Bon Secours Corporate Director of Operations and Finance and worked directly with the VP of Operations, Finance, and CFO on the coordination of strategic projects, including operations improvements, mergers, divestitures, cost accounting, service line analytics, and projections. During this time, she also covered critical senior finance staff transitions, including a stint as interim CFO. Katie is a board member of the Maryland chapter of the Healthcare Financial Management Association and Charleston Senior Living Community. She has a Bachelor of Science degree in Accounting and Information Assurance from the University of Maryland, College Park, holds an active CPA license in Maryland, and is a Healthcare Financial Management Association Fellow. So please join me in welcoming Katie Eckert.
Good afternoon, everyone. Okay, so thank you, Connor, for that introduction. So today I am going to humbly attempt to cover the current U.S. healthcare industry outlook in about 30 minutes. So we've got a lot to get through. As you know, this industry is really complicated. Most of the morning really focused on what's going on here in Maryland. So we're going to shift perspective a little bit, and we're going to look outward of what's happening across the rest of the country. A lot of those trends which are also in Maryland as well. Next slide, please. So we are going to, go back one, there you go. Okay, so we are going to highlight some of the major forces that are shaping the industry, touch on those themes, and try to talk a little bit of how that's going to look, intersect with the Maryland model. We are really jammed on time, so I'm going to get through this as quickly as possible. Next slide, please. Okay, let's get into it. So over the next 30 minutes or so, I'd like to step through these 10 major trends shaping the healthcare industry. There's also some cross-cutting themes that we keep popping up as we go through these trends. And I am not going to read you guys these slides, but if you need me to stop or pause or clarify, just wave at me, raise your hand, and we can stop. Can everyone see these okay right now? Okay, thank you, Linker. Okay, so next slide, please. Let's start with first cross-cutting theme I'd like to talk about is our aging population, which will set the backdrop for many of the trends we're going to talk about. This is what was the silver tsunami. It's the wave of baby boomers aging through our healthcare infrastructure and creating that bolus of demand. So by 2030, all the baby boomers will be 65 plus and eligible for Medicare. That's just in 7 years. Fast forward to 2040, and we hit the beginning of the sweet spot for 75 plus, where the most people will have their peak healthcare use. And that's within the next 17 years. And then by 2050, we will have the largest 85 plus population ever that we've ever had in the US healthcare system. So that should really kind of set the stage for some of these huge trends that are coming and this population of patients that are going to need care. So next slide, please. So this is a very big deal for Medicare. The most recent Medicare Hospital Trust projections I could find were roughly June 2022, that Kaiser Family Foundation put out. And so they are projecting that with the increased demand coupled with the depletion of funds from lower taxes collected during the COVID era, that the hospital inpatient fund will be depleted in just 5 years. With no major changes. So that's by 2028. On the right are the annual projections that fluctuate with changes made to the Medicare program. So for example, increasing the age of eligibility for Medicare is going to extend the coverage of the funds. So, and some of this you've seen in the press too, with physician payment rates and cuts to those, depending on, that calculus of demand and payments is what all the very smart actuaries use to figure out what the fund coverage will be. But the point here is we got a situation. So this should hopefully help articulate the sense of urgency that the federal government has to bend the cost curve for healthcare in the US. The aging population and our healthcare needs And the lack of sustainable Medicare funding is the backdrop for the next 10 trends that we're going to talk about. So next slide, please. Okay. So let's get into the trends. First up is the unprecedented financial pressures facing healthcare today. Recent hospital flash report showed 11 straight months of negative hospital operating margins. Next slide. And of course, go back one. Thank you. And of course, we can't talk about financial barriers in healthcare without talking about, and change in healthcare without talking about our incredible clinical staff and the limitations and the breaking point that we're at now. Please. The advisory board did a great visual here to show how workers are migrating out of those traditional institutional facilities. Think about your coworkers or your friends or family who are nurses and they're working 12-hour shifts, 3 to 4 days a week, right? That is not typically the ideal schedule that someone's looking for. I have a friend, she's looking for working in an ambulatory setting, an ambulatory surgical center. She wants something closer to a 9 to 5. She wants something that she can manage, and still see her children after school. So that's just one small vignette, but this is a huge trend that many think is helping to be one of the major drivers of pushing care out of the institutional settings, because it's easier to staff some of these ambulatory settings and outside the physician offices. So it's forcing the movement of patients into those settings. Next slide, please. Which leads us to our next major trend, and that is the accelerating shift of care out of institutional settings. The workforce pressure is just one catalyst. Next slide. So I know this is probably small for in the back of the room, and I believe the slides are going to be sent out after the presentation. So SG2, as many of you know, is an industry leader in market projections. The most recent outlook, published in 2022, projected a rise in patient acuity, but a decline in inpatient hospital care. And they projected that length of stay would grow 8% over the next 5 years and sustain over the next 10 years. And I see a lot of nodding heads. That's what we're feeling right now in our hospitals. We're experiencing it. So some of the reasons that they cite in their projections, which if you read through this, the top line is about inpatient, but then the rest of these dot points are about how care is going to move out of the hospital. And so some of the forces, aside from workforce challenges, are patient preferences. The patient doesn't want to go to the hospital. I know I have a neurologist, and I have the option to go to Bayview or to do a televisit. Let me tell you, I will do whatever I have to do a televisit. I do not want to go to the hospital. So patient preferences are coming into play. From a profit margin perspective, even though you get reimbursed a lower amount in these ambulatory or non-institutional settings, you have a higher margin potential outside the hospital. So that is also another factor here. Also shifting clinical protocols. I mean, how many people remember when you were an inpatient when you wanted a knee replacement, and now it's predominantly an outpatient procedure? As clinical protocols have shifted, as the technology becomes available, a lot of the diagnostics are moving out of these institutional settings. And then, of course, the explosion of telehealth, which COVID really ripped the Band-Aid off for a lot of users getting there. Next slide, please. So McKinsey, in their market outlook, are projecting that the current home care market alone could multiply by 3 to 4 times its current size by 2025. I had to stop myself and read this and look at it. What are they talking about? That's just unreal to me. But this is a current article and a current projection. And what I liked about this visual is that it took the current market and then showed the different carve out for the different services that they think are going to be moving into some of this home health and telehealth capacity. So some of the largest players placing big bets on home health in 2022 are some of the big payers. So United Health Group, for example, just signed a $5.4 billion deal to acquire home health provider LHC Group. They're a huge national group. That transaction is supposed to close early in 2023. CVS just signed an $8 billion deal to acquire Signify, which is another home health provider. They were competing with Amazon in that space. And this is just an example. I mean, you can go look at the headlines. I mean, it's just fascinating seeing all of the activity in this space right now. So a lot going on with big retail and also payer activity. So next slide, please. Thank you. So that leads me to my next topic. You like how we're just kind of cascading into each topic. There is some, the role of the payer and some of the dramatic shifts are projected in the insurance market. So let's go to the next slide. So due to the pandemic, there were some really big shifts in employment patterns, and a lot of folks get their insurance through their employer. We know this. So employer-sponsored coverage decreased, mostly due to unemployment. And a lot of it shifted into Medicaid managed care because with the public health emergency, there was expanded funding, access to Medicaid, and states were suspended from disenrolling people during the PHE. And so these policies, which are allowing folks to stay on managed Medicaid rather, will expire when the public health emergency expires. So an estimated 15 million enrollees will gradually leave Medicaid, and some will shift to coverage through the marketplace or their employers or become uninsured. We just don't know what's going to happen. So we do expect some really big changes to happen. And as of January 11th, we could have entered the last 90 days of the PHE renewal, which will be the catalyst for this big shift. So a lot to look at over the next 90 days to see, or rather at the end of these next 90 days, we could have more coverage or we could have less coverage, but all we know is there's going to be some big changes. It varies dramatically by state and by county. And in Maryland, we have one of the lowest penetration rates at 21%. One of the things driving MA profitability is the ability to negotiate networks of care and lower rates. Because of Maryland's model, we have some of the highest hospital prices in the country for Medicare patients. So it's not an advantageous market for MA plans, which is why we don't currently see the penetration in Maryland like we do in the rest of the country. And this has really big implications for the future of our model. With Medicare, since our model is based on traditional fee-for-service performance, as folks move on to Medicare Advantage, they are pulled out of our test calculation. They don't count. We only get measured on fee-for-service. And so as more of the national Medicare population shifts into MA plans, they are excluded from the national tests that we're measured against. And so this dynamic is shifting the risk profile of the patient population Maryland residents are being measured against. So imagine if we only have 20% of our population on Medicare Advantage, but nationally they've got 60% or more. There could be something significant in the demographic makeup of the patients that are in our fee-for-service population versus the nation. We don't know. It's something that we need to factor into it's something we haven't had to factor into our model performance previously. And it's definitely something to keep our eyes on as a state as we look to the future and our ability to generate savings for Medicare. Next slide, please. Another major trend in MA is that two of the heavyweights, United and Humana, dominate the market and account for nearly 50% of all MA enrollees. So again, there's some really major implications when you've got two companies that are dominating the market. They're going to be able to set the trend. So that's something to keep in mind with MA that's really being controlled between those two firms. Next slide, please. Okay, so talking about firms that own a lot of the market, let's segue into the rise of mega healthcare companies. As payers integrate vertical networks, some refer to the giants as payviders because they're not only the payer, but also the provider. So let's go to the next slide. I cannot take credit for this slide. There is a fabulous woman named Victoria at the New York Hospital Association, and she is an expert on all things payer related. And so she put together this slide that shows by health plan how some of the major health plans have started to do vertical integration. So you can see, like in the first column, Cigna has bought a PBM. They have Express Scripts. And then they don't have a retail pharmacy, but if you go over to the CVS Health column in the middle, CVS has a PBM. They have a retail pharmacy in their CVS clinics, but also Target. They also have a primary care and disease management specialty. So you can see how they're getting the full spectrum, and it gives them full sight lines, 360-degree view on the patients they're providing care to. But then if they're the insurer, they know who their bennies are, which is something that we in hospitals can't necessarily see. We really only get to see the patient when they walk into our health system. But the providers have access to that beneficiary information. So they're really positioning themselves to not just be the provider, or to be the payer, but the provider as well in some of these situations. I'm going to talk about Optum, for example, on the far right, and United Healthcare. So Optum is a subsidiary of United Healthcare. They have an array of healthcare services from surgical centers, doctors' practices, clinics. They have a pharmacy management company. And they also have Optum Insight, which is a data analytics, research, consulting, technology, and managed services solution. So it's a Swiss Army knife when it comes to all the different facets of healthcare. Optum is used by 80% of health plans, and Optum Insight serves 90% of US hospitals. I almost fell out of my chair when I saw that statistic. So they have the information, they have the technology, and they have the cash to be able to be strategic in the market and strategically positioned to bend the cost curve and get into future space. Another one that's not on here is Dollar General. You may have seen some of the recent press that Dollar General is partnering with DocGo to pilot mobile clinics. They're actually not even using their real estate. They are actually taking vans and driving them into the parking lots of Dollar General stores. So 75% of the US population is living within approximately 5 miles of a Dollar General store. And so everyone's watching them really closely because they have the potential to be a massive disruptor to the industry, because they have a physical location. And one of the things that they're looking at doing is some type of telehealth out of some of these locations. And a lot of them are in some type of healthcare desert. And think about, the rural healthcare challenges that the rest of the country has. In Maryland, we've been able to really support our rural hospitals. But in the rest of the country, you see all these critical access hospitals and rural hospitals shutting down because they just cannot make the business model work when you've got this huge fixed cost structure of a hospital. It just, the math doesn't work. So enter in the Dollar Generals of the world, or Walmart. I also don't have Walmart on here. But what Walmart is doing, something a little bit different, they're actually using trailers that they're building out, speccing out as a clinic. They are then delivering them to Walmart, and they are bolting it onto the store, popping a door in, and then they are staffing them as health clinics with lab services, imaging, primary care, dental care, behavioral health. And they're actually, it's really interesting. A lot of the folks entering the space are doing nurse practitioners or some type of a mid-tier provider. Walmart is hiring physicians, they're hiring MDs. So everyone's really watching them to see how they're going to disrupt the primary care space. And something to keep in mind, like in our Maryland model, total cost of care, we have the same price for anyone who walks in the door of one of our facilities, right? Well, Walmart's doing the same thing. It's the same flat fee for anyone who walks in, $40 for a primary care visit, $50 for a dental checkup, $45 and cleaning, $45 for an eye appointment, and $1 a minute for a therapist, or $60 an hour. I'm looking at my insurance, and I have good insurance, saying, well, shoot, I mean, if the providers are good and they've got good quality outcomes, like that's going to be the trick, right? But let's assume that they're able to pull off this quality. Even with insurance, it would be cheaper for me to go and get care at Walmart than to go through insurance and pay those insurance premiums. So when I talk to colleagues across the country, we're not really looking at we're watching other hospitals and health systems, but our true competitor is what's happening in this space where they're completely changing the business model. Okay, you can tell I get excited about this. So let's go to the next slide. Okay, so let's not forget the pressure on health systems. A lot of health systems are consolidating due to needing to leverage their cost structure. So it's really, really expensive. There's a lot of fixed costs. If you can merge, then you can leverage those back-end fixed costs. There was a big pause during COVID, but Kaufman and others are projecting a resumption of the M&A activity for health systems in 2023. And these aren't going to be small mergers. They're projecting big mergers to be happening, assuming that the federal government does not block or prevent any of them, because that could be a potential barrier in that space. Private equity and venture capital trends through 2021. So this is a little bit outward look, or backwards looking, but you can see this has been ramping up. It's kind of getting a fever pitch now with technology and the volumes with the baby boomers coming to a head. They're thinking that there's a lot of opportunity here. And you can see that what's happening in the healthcare sector way outweighs the US industry average. Next slide. Okay, so I'm going to segue now into another part of our ecosystem that is experiencing a shift in their business model, which are physicians. So let's go to the next slide. Physician business model is being shaped by a projected shortfall in providers. Similar to the nursing crisis, physicians are also aging out and experiencing burnout. They also are looking at Medicare fee schedule cuts to keep Medicare solvent, so that's putting pressure on a lot of those private practices. Another force here on the physician business model is the rise of tech-enabled super practices. And the whole idea behind these is to drive patient-centered care and to achieve value-based performance. They are innovative, they are tech-savvy, they're using data to personalize healthcare for patients and drive value. So next slide. So let's talk a little bit more about this trend and the shift to value and risk-based care. I am just going to barely scratch the surface on this. Any of these topics alone could be a full presentation. So the goal for today is to leave you with the highlights so that you have a rough framework of what these major forces are. So the industry has focused on addressing health equity. This is a really big deal. So let's go to the next slide. There's a couple different driving forces here, and I'm just going to touch on some of them, some highlights, particularly from the federal perspective. So COVID-19 really brought this to a head, and there was a presidential health equity task force report released in 2021 that had a top 5 recommendations list, which is on the right, and this is driving to support cross-agency prioritization of addressing health equity. Let's go to the next slide. So we're seeing CMS really make this a priority. They released a health equity framework report for 2022-2023, and we're starting to see components show up in new payment models. So the ACO REACH model, which stands for Realizing Equity, Access, and Community Health. It is an example of how these big lofty recommendations are making their way into actual payment policy on a federal level. And it requires the development, the ACO REACH model, of a health equity plan with steps to identify health disparities and specific actions to address them. Let's go to the next slide. The Institute for Healthcare Improvement did a pulse report in 2021 asking for health organizations' priorities, and health equity popped up to be one of the top 3 priorities in 2021. It jumped from being in 25% of respondents to 58% of respondents saying it was a top priority. And you also heard this several times in Katie's comments earlier this morning, that this is a really big priority for the state. So health equity is becoming a major force shaping the healthcare landscape. Let's go to the next slide. I don't have a good segue into this one, but our patients are getting more complex. Behavioral health is projected to explode to unprecedented levels. It's already a problem. COVID made it worse. Maybe COVID uncovered things. But it's definitely projected to have huge need. Let's go to the next slide. Here's a projection of the market growth for behavioral health through 2027 to give you a flavor of how fast the market's expected to grow. And to touch on like one of our cross-cutting themes here, earlier this month, CVS Health just led an investment round in virtual psychiatry and a therapy platform called Array Behavioral Care. So again, getting into those big mega players, getting into the space. There's not enough providers. Telehealth technology is the solution to meet the demand. It's all coming together, right? In theory. All right, let's go to the next slide. We already have a problem with chronic disease. We know this, but it's projected to get worse, a lot worse, particularly with COVID. But it was going to get worse even without the long-term COVID issues. Let's go to, so let's talk about rising risks from extreme events. This was not something that was on my radar, but I was reading all the big industry outlooks that kept coming up over and over again, and it makes a lot of sense. So let's go to the next slide. Cybersecurity is a really big deal. A study in JAMA was just released that healthcare ransomware attacks doubled in the last 5 years. Let's go to the next slide. But it makes a lot of sense, is extreme weather is expected to add a lot more volatility to U.S. Healthcare. With projections for more extreme events, S&P actually listed this as one of the negative trends for their industry outlook. It has major implications for disrupted care, damaged facilities, and supply chain volatility. So let's go to the next slide. Here is NOAA's recap of the 2022 only the billion-dollar events. This is just the billion-dollar events. And this doesn't even get into some of the issues, issues in our cities that come with that. So another article that was talking about the intersection of healthcare and climate change, and that there's some major implications with air quality and COPD and things like that, and obviously rising chronic conditions. It's all comes together in a big cluster. So this is definitely another factor as we look long term, not necessarily just in 2023, but out over the next decade or two. Okay, next slide. So that was a lot. Thank you for hanging with me through that. It was fast and furious. I have no idea how I'm doing in time. But the goal today was to leave you with a very strong overview of the major themes. Because again, we could do an entire presentation on any one of these topics. So I guess I'll take questions if there's time.
For you, anything? If there's any questions?
I got one. So Katie, thank you, by the way. This is a lot in a short period of time. I guess maybe this is more your personal opinion. You have to cover 10 trends and some other themes on the right there. What do you think from a provider sense? And maybe we can pair if we have time for that. Top 2 or 3 things that if you're sitting there with a provider, kind of thinking more at a macro level, not necessarily the agency battle that everyone's fighting, and some of the, what else should people be top of mind from your opinion and all your research you've done?
So I think from a provider level, and I might, so I've been at the Maryland Hospital Association for the last 3 years, and I'm about to join Adventist Healthcare and get back into provider space. So I haven't been in the trenches. But I think if I had to answer the question today, with the knowledge that's in my head today, it would be, and HSCRC, put your earmuffs on at this point. The hospital is a dying business model. It's just too cost heavy. The infrastructure, just so capital intensive, that what I've really been watching closely is I think we're at a tipping point where hospitals don't make money, they can't break even, and they're actually losing money for a health system. And so I think that has really big implications of how do we deal with that and deal with caring for the patients that do need acute care in the hospital. But I don't think that the very capital intensive way and physical infrastructure way that we care for patients is sustainable at present. So I would say that, and then watching all the disruptors, like watching Walmart down the street and what they're doing. So trying to navigate those two I don't know, mountain ranges, like as you're going through it. And for the payers, I really think it's the demographics of the population. And I'll look to my Care First friends in the room, but not ever working behind the desk of a payer business. I would think that would be a huge deal. As we have this huge bolus of beneficiaries that are going to be needing some intense care, and we don't have the infrastructure currently to provide it.
Thank you. So I was going to ask, which of these national forces do you see as the biggest potential to impact our Maryland ecosystem? But hearing that last answer, as folks who play in the regulated space largely, what are some ways that we can apply what you were just saying going forward?
So I think one of the things that we're really going to need to pay attention to, and this is Katie Eckert speaking, not the Maryland Hospital Association or Adventist Health. I think one of the things we're really going to have to watch is the risk profile of our patient population. The way that our test is structured with Medicare right now, it is against a national average. And they are also measuring us relative to a matched cohort. But our actual technical test is against the national average. So I think that we're going to have to get really smart about the way that we look at our at those tests and the way the tests are calculated. I'm very concerned with the shift into managed Medicare Advantage outside of Maryland, that the demographic profile of those patients is shifting faster than what we have here in Maryland. We could be in a situation where we have sicker patients here on fee-for-service that nationally are moving into these specialized needs plans, which we are seeing big growth in the S&P plans. So I think it's something that we need to look at and watch and not be caught off guard by. We don't have a risk-adjusted model right now. I'm not necessarily being a proponent of it. I think we need to be smart. I think we need to run the numbers. I think we need to know what we're working with and just not go into it blindly. So I'm not a proponent for risk adjusting or for not risk adjusting, but for us to make informed decisions about how to be successful in the model, if that answers your question.
Thank you. Other questions?
And I'm looking to William to make sure that I did not answer that inappropriately.
It's been okay so far.
Okay.
Well, I'll have you guys know Katie's on vacation right now, and so she's spending her vacation with us. So we thank you, Katie, and the lesson learned from that is don't answer James's phone calls.
Yep, that's the lesson learned.
So thank you, everyone.
All right, thank you.
Hello, everyone. My name is Megan Priolo, and I'm thrilled to announce another Megan Renfrew. Megan Renfrew is the Associate Director of External Affairs at the Maryland HSCRC. She collaborates with stakeholders to develop regulations, policies, and reports on a variety of topics, including medical debt, hospital financial assistance, behavioral health, and Maryland's Advanced Primary Care Program. Prior to joining the state of Maryland, Megan worked for the CMS on 1115 demonstrations and the collection of Medicaid enrollment data. She also served as a nonpartisan attorney in the Office of the Legislative Counsel in the U.S. House of Representatives and contributed to the drafting of the Affordable Care Act. She has a Juris Doctor from Columbia University, a Master of Public Affairs from Princeton, and a Bachelor of Arts from Cornell University. So welcome, Megan.
Good afternoon, everybody. So I know I am getting the slot where your lunch is now in your stomach and you're probably a little bit tired. So I am going to ask if you're willing, because there wasn't a break between that Katie's really incredible presentation and mine. You just stand up. All right, put your hands behind your head. Twist from side to side. All right, and then sit back down. Just get that blood flowing a little bit. All right, cool. Thank you. I love the participation also. So I am here today to provide an update on requirements for hospitals related to financial assistance and medical debt. The law has changed several times in the past few years, so I thought it was a good time to come and provide an update. However, before I dive in, I want to ask some questions of the audience. We're going to stay on the slide for a little bit, so you're aware. So this is just a raise of hands. How many of you have a loved one, a friend, or a colleague who's been impacted by medical debt? Got a couple of hands here. Yeah. I think certainly we're all aware of people who use GoFundMes, right, who are really struggling, facing debt that is hard for their families to handle. All right, so then how many of you in the room have a professional responsibility for either financial assistance or medical debt, that's part of your job? Got a few hands on that too. Okay, great. And then this is where I'm going to ask somebody to volunteer to give an answer. What would you say the relationship is between medical debt and health? Any volunteers? I saw some hands moving over. Yeah, so medical debt goes up, health goes down. That is what the evidence shows. So it's a bit of a cycle. People with greater health needs incur more medical debt, but the evidence suggests also that medical debt itself may impact health outcomes in a couple of ways. So first, it affects your ability to pay for other things, to pay for food, to pay for housing, to pay for utilities, and those are key drivers of health. It also causes stress, and that affects mental health, and it also affects our behaviors. I'm someone who sometimes emotionally eats. That affects my health. So similarly, if you're under a lot of stress because of financial reasons, that may affect your health outcomes. It causes also reduced use and access to the healthcare system. One study found that about 46% of people who carry medical debt avoided care. So that can also have a long-term impact on health. It also can limit your access to neighborhoods because it affects credit. Then maybe you can't lease a home in a neighborhood that's quite as good or buy a home in a neighborhood that is quite as good. And by good, I mean safer, where there's access to food in the form of grocery stores, where there's access to green space, and those things, again, directly have impacts on health. So then my next question is, what is the connection between medical debt and equity? The answer's there. Yes.
I mean, medical debt is more prominent in folks with, that don't have the equitable access for whatever reason.
So the answer for those of you who are online, medical debt is more prominent for people who don't have equitable access for various reasons. So thank you for volunteering twice. I appreciate that. There was a report released recently from the Federal Consumer Financial Protection Bureau that found that medical debt tended to disproportionately affect Black and Hispanic people, young adults, low-income people of all races and ethnicities. And then there's also impacts of medical debt on older adults, just because their healthcare costs are so high, and on veterans. So those are all really important populations to think about in this context. The burden of medical debt is significant. A 2018 national study found that 22% of consumers nationwide had unpaid health bills, and that percentage had increased over the 3 years between 2015 and 2018. So, you are all math people, I'm a lawyer, I'm not, but that's 1 in 5, that's pretty significant. There are a lot of policy decisions that Maryland has made that help reduce medical debt in the state. And I did want to bring attention to that. Some of these are 10 years old or more. So the expansion of Medicaid about 10 years ago made a big difference. States that did not expand Medicaid had much higher levels of medical debt. The subsidies we have in the Maryland Health Connection, most of those subsidies exist nationwide, they're federal law, but we've added a subsidy for young people. So that helps with some of those disparities we're seeing in the younger population. So those have made a big difference on medical debt in Maryland compared to other policies. We could see that directly through our data on uncompensated care at hospitals. We saw a big drop in uncompensated care in Maryland when the Medicaid expansion went into effect. And it's not exactly comparison, so I use that 22% figure for nationwide. These are different methodologies, different data sets, but 2020 review of consumer credit panels found that in Maryland, about 12% of people on those credit panels had medical debt. And that's on the lower end of states, and they also have lower amounts of debt. So there's a lot of ways in which we are doing very well in Maryland at helping keep medical debt low, have it burden less consumers. I do want to note, I'm going to spend the whole rest of the presentation talking about all the requirements related to financial assistance and medical debt. I do want to put a little plug, particularly for Jerry's sake. HSCRC always expects that hospitals will engage in reasonable collection efforts to collect what is owed to you within the constraint of the law. So a lot of what I'll be talking about today is that constraint of the law part, but this does not counter your responsibility to collect. Because that in and of itself keeps access to services, it keeps your businesses going, right? So that people can come get healthcare. And it helps to keep our UCC fund sustainable. We really think our UCC fund is, uncompensated care fund, is a value of the model in Maryland, that ability to make sure those hospitals that have the highest burden of uncompensated care are able to access funding for that. I cannot say how much I love that is a component of our model. I think it's incredibly important. But if we all of a sudden started writing everything off, that would break down. So that's, I'm just doing the footnote. Please continue to collect after I say everything I'm going to say. All right, next slide. So what I'm going to do today is talk about the legal changes that have happened in the last 3 years, and also just give a quick summary of our law on financial assistance and medical debt. And then I'm going to talk about some of the things that might be coming down the pike. We are not at the end of changes in this space. So there's going to be more changes, which I'll need to update you on in some way in the next year. So next, we can go 2 slides. Yep, great, right here. So this is just an overview of financial assistance eligibility in Maryland. So at the federal level, federal law under the Affordable Care Act says that nonprofit hospitals need to provide financial assistance, but doesn't provide a lot of rules under that. That's part of your nonprofit status. It's in the tax law. But here in Maryland, since 2005, we've actually had very specific requirements on financial assistance that hospitals need to provide. They have changed a few times, but right now, hospitals are legally required to provide free care to patients that are under 200% of the federal poverty level, at or under, reduced cost care to those that are between 200 and 300%, and also reduced cost care to people who are under 500% FPL and have what we call financial hardship. That's the term of art we use here, but what that really means is that they're people who are carrying a high level of medical debt. I have included the legal citations at the bottom with, I don't know if the links will come through when it gets shared with you, but in case anyone wants to go look at the law, that's where it is. So in eligibility changes, there's changes in notice requirements. The information sheet, which has been required for a long time, now must include a space for the patient to initial to indicate that the sheet was received. Unlike the facility fee notice, we don't require the patient to initial here. So the facility fee notice, I know that's complicated, and I'm not commenting on the facility fee notice today, but I just want to be clear, it is very much not required here. You just have to have the space for them to do that. The information sheet also must be available in each language that has more than 5% of the population in your area. Next slide. So the two other changes I'm going to talk about are denials and reporting. The law now does require that hospitals have a process to allow patients to request a reconsideration of a denial of financial assistance. So that needs to be built into your policies. We also now have additional data requirements. And I know many of you have now reported these to us. We just collected our second year of this data. So we now collect data on the number of financial assistance applications, the number of denials, and for people who received financial assistance, we ask for the reports on those people by race, ethnicity, and gender. I want to point out that data set, we're collecting it through a form called the DCFA, Debt Collection and Financial Assistance is what that stands for. That data is required to be reported to the legislature. This issue is politically hot. So I just want to point it out to you that that is true. The advocates for consumers are very, very engaged here. And so just know that it's not just a form that's going to HSCRC that's going to sit in a file cabinet, the virtual file cabinet somewhere, but it does go to the legislature. It's going to get sunshine. So I'm about to turn to medical debt, but I did just want to, it's on the bottom of all my slides, and I'm going to bring it up again in this presentation. But one of the reasons I wanted to bring this to you today is just to have a reminder that if you haven't looked at your financial assistance policy in a while, it's a good time to look at the law and look at your financial assistance policy, at your processes, and at your training for staff to make sure that you're in compliance, given that the law has changed a couple of times in the past year. So next slide, and then we can go to the next one. So I'm turning to medical debt now. Maryland law has also regulated medical debt collection for hospitals since 2009. So we've had regulation in this space for a long time. To summarize here, hospitals have to have a debt collection policy that has to meet the requirements of the law. I'm not going to go into a lot of detail in the law. It is long, and there are a lot of requirements in there. So you have to have a policy, and it has to be aligned with the law. There are some things that are a little bit unique in Maryland. We do not allow the sale of medical debt. That is not true in all states, and so that's an interesting aspect of our system. Hospitals must have a process for providing refunds to patients who qualify. This is generally patients who paid a bill, but then you later figure out that they were eligible for financial assistance. There is a new requirement that hospitals provide payment plans to patients. I'll talk some more about that later. We used to have a requirement for payment plans only for people under 500% FPL. That's now no longer the limitation. So you need payment plans. More assets are protected from debt collection than used to be protected. There was always some protection. That list has gotten longer. The statute also has very specific rules about when hospitals can report patients to credit reporting bureaus and when hospitals can file in court to collect medical debt. All right, so next slide. So I'm going to talk about the changes similar to what I did with financial assistance. I am going to point out here, I am focusing on state law in this presentation, not on federal changes. In the space of medical debt, federal changes are relevant. Regulation F from the Consumer Financial Protection Bureau came out relatively recently. That regulates debt collectors or collection agencies, however you want to put that, the folks who do the work of, for many of you, of following up with patients who have outstanding bills. And so that is something I am not an expert on, not going to speak to. Just wanted to say it has changed in a similar time frame. So we did have a major, at the state level, medical debt law in 2021. This law is cited by consumer advocates as one of the best laws in the nation for protecting consumers. And so, sort of, to put that means it will impact your business, right? So I think it's important to know just how significant this is. The law created the concept of income-based payment plans in Maryland. So for income-based payment plans, the monthly payment under those plans is capped at 5% of the patient's income. There's positives for consumers here, right? Having payment plans available, having capped payments does mean that they can avoid, for example, high interest credit card debt if they're trying to pay their bill that way. For you all, it will extend the length of payment plans, right? It will, if there's a cap on how much you can charge each month, it's going to cause the term of those payment plans to be longer. I know that many hospitals in Maryland don't charge interest on the payment plans that they've offered in the past. That may be something you want to consider. Interest is allowed in the statute. Our proposed regulations, which I'll talk about later, did have a limitation on the interest amount, but you just might want to consider as these payment plans get longer, whether that cost to you means that having no interest payment plans still makes financial sense. I am not taking a position on that. How you run your business is yours. I just wanted to point it out. There is also a slight change to the provision related to refunds for bills for people who are eligible for financial assistance. Next slide. There are a lot of rules around credit reporting in the changes to the statute from 2021. Specifically, you cannot report information for uninsured patients or for patients who are eligible for financial assistance. And I just want to bring this back to the conversation we had at the beginning of the conversation. I think the consumer advocates were really interested in these credit reporting issues because of the effect that bad credit can have on many other aspects of a person's life, right? Employers sometimes look at credit reports. It can affect your ability to get housing. It can affect the cost of debt. So if you need to buy a car, it can affect your interest rate. Also utilities and utility providers often look at credit, and it may also affect insurance premiums. So credit has a real impact on consumers, which I think is why they were so concerned about this. There are national changes to the reporting of medical debt to credit bureaus that are not reflected in this slide, but I did want to point them out to you. In 2022, just last year, the Consumer Financial Protection Bureau released a report on medical debt, and consumer finance very soon, close in time to that, the three largest credit bureaus removed all paid medical debts from consumer credit reports. That happened in July of 2022. That removed approximately 70% of negative credit debt remarks from consumer credit reports.